one of the things that separates you from most other jaw surgeons is your use of custom plates, custom printed plates.
Right.
Most everyone uses sort of pre-surgical planning.
Correct.
Electronic software-based planning.
Right.
But then they'll take that planning and they will bring it to the surgery with a splint. Is that right? And then they will actually bend the plates on site during the surgery according to the electronic plan.
Exactly.
But you differ from that.
Correct.
In the final step.
Right.
In that you do plan electronically. You obviously have some sort of splint that's involved, but the plates themselves that hold the movements forward are printed before the surgery even starts.
Correct. Yeah, they're printed to the exact shape to be flush with the bone in the new position. So they're providing multiple purposes. One purpose is obviously to fix the bone and hold it there till the bony gap fills in and the plates are no longer needed. But also, that's the direct usage of the plate, right? That's what we think of plates for, to stabilize or fixate the moved pieces. But what that plate does also, because it's preformed to put the jaw in the exact position, it acts as the GPS, or the transfer of information from the virtual plan to real life. And the way it's done traditionally, I mean, when I trained to do it 15, 20 years ago, we didn't even have virtual surgical planning. We used to use stone models and perform surgery on stone models of teeth. And then we used acrylic to make these splints in between the teeth to act as the transfer of information in the operating room. What we would do is we'd wire the mouth shut. We'd wire both jaws shut into that splint. And that would give us the information once one of the segments are loose, where that bone should be. We would still, for vertical position, have to measure, because the only thing that splint can do is give us some information, but not any vertical, because you can keep it and plate it in any vertical position, so you would still have to measure the vertical position. Now, and
not to sidetrack you, but just in terms of practical application, what does the vertical position determine? Tooth show?
The biggest thing is tooth show.
Gummy smile, eliminating gummy smiles, but also not hiding the teeth.
Correct.
So you got to strike that sweet spot.
Yeah, probably one of the most important determinations to make in planning, actually, and then in execution, but in planning for sure, is where to put that incisor, where to put that tooth show. Are we going to bring it down? Are we going to bring it up? Because that can change the aesthetics tremendously. You know, a buried upper jaw that shows no tooth show looks older, right?
Right.
It ages the person. It doesn't produce a good smile. Whereas one that's excessive looks very gummy and too much tooth show.
Yeah,
absolutely. Resembles what we see as vertical maxillary excess, which is actually a condition that we're trying to treat a lot of times. So there's a sweet spot that's in the aesthetic zone. Mm-hmm. And to get that vertical without using custom, you have to measure. The way people measure is either measuring from the medial canthus. This is what I used to do before custom days. I used to take a bully gauge ruler and measure from the medial canthus to the tip of the incisor.
And where is the medial canthus exactly?
The midpoint of the eyelid.
Oh, okay.
Yeah, where the eyelids meet, near the nose.
So in surgery
on the table,
blood, fluids, drapes, and now you're trying to get this ruler.
Yeah, you get this ruler and you're measuring millimeters, because a millimeter, it makes a huge difference with tooth show. So it's a big distance to measure from. It's no way it's accurate. Another way that surgeons do it, they're just more fixed than the eyelids, is they put an actual wire in the skull. They call it a K-wire, and they use this big power drill while the person's asleep, drill a wire into the skull, and they'll measure from the wire to the tooth. But again, huge distance, the margin of error, there is a margin of error.
Yeah.
To determine that vertical, so it's not ideal. So even in today's standard, where we don't do stone model surgery anymore, we're doing virtual surgical planning.
Everyone's doing
that, but most people are still going to the operating room doing it the traditional way, meaning they virtually plan it, but in the operating room, it's the same as the Stone Ages. They're transferring that information from the computer with wiring the mouth shut in a splint, measuring distances from a K-wire or the canthus, and bending the plates. So even though we have new technology, it doesn't change the actual execution of the surgery unless they go next level up and start using and understanding the custom workflow. Because now truly do we take a virtual surgical plan and we can execute it with accuracy.
Right. So you mentioned the vertical dimension as being one metric that is sort of achieved archaically or with this traditional method, but that's not the only thing that custom plates can help you nail with precision. There's
so many.
So
yeah, it's very 3 or 4 dimensional. Right?
Yeah, right.
It's all aspects. So things that are really important when setting the jaws are orientation in all accesses. We talked about this earlier. If you know, in aviation terminology, pitch, roll, and yaw are planes, right?
Yeah, maybe we could demonstrate on this model.
Yeah, so here's a model right here of a skull, and some people have a very steep plane angle where their chin is far back. The way their teeth line up is like a ski slope.
Yeah.
Right? So they require a counterclockwise rotation. This counterclockwise rotation is a change in pitch, right? Some people have a yaw deformity, which means that the jaws are like this, where one cheek is more forward than the other cheek. One side of the jaw is more forward than the other side of the jaw. There's some asymmetries. These are pretty common. So we have full control to fix that orientation in the yaw position. And the same with the slant. A lot of people have a slant. We call it a cant.
That's what a maxillary cant would be.
Exactly. And that's the roll. So we have control in a computer to orient all these things perfectly. You know, a 0 cant, 0 slant, a pitch that's 7 degrees, which is ideal, not 14, 15 degrees, right? Mm-hmm. Or not negative, not a negative pitch, which is also abnormal.
Sure.
Yeah. So we have control of that. And then the yaw is important to control. Now, to get all those things accurately, very difficult when you're just bending plates and putting it there. You have very little control because all you have control of in that situation is at the teeth level.
And just to be clear, everyone is planning these corrections virtually.
Everybody's planning it virtually, and everybody in the operating room is trying to get exactly what they planned. That's the goal for every surgeon. No surgeon is going and artistically sculpting like Michelangelo.
On site.
That would be catastrophic.
As you said earlier when we were off camera, this is not stone.
Right.
It moves on the table. It's soft.
Exactly. Like even Michelangelo couldn't on the table fix pitch, roll, yaw, vertical dimensions on the table because it's not stone. The person is oriented a certain way. There's drapes over the person. So we have the body and the face covered, and then there's swelling that occurs as soon as the surgery takes place. So
they're not strapped down. So their neck is
so there's no way to have adequate orientation to on the table, free-handed, artistically put it. It would be catastrophic, even in the best, most artistic hands. That's why in surgery, even in the Stone Ages, whatever was planned, all the plan is done beforehand. And then the tools were just the tools to transfer that information from that plan into the operating room. And traditionally, it was splints and wiring the mouth shut, and then bending the plates. The splints and wiring the mouth shut was that transfer of information, albeit there's a lot of margin of error or levels of error in that transfer. With the custom, it's direct to the bone. The plate is giving us that information to know that we get exactly what we want. So it's much more predictable,
right,
stable, and efficient. So people, we're proud of the surgery times we have. It used to take me 8 hours to do an operation. Now it's taking 1 hour on average to do a double jaw surgery. 800% faster.
Right.
It's not, I'm not talking about 10% faster, 20% faster.
Right.
We're doing it 800 times faster, 500 to 800 times faster than experienced surgeons.
Yep.
Professors, attendings, legends. And it's because the technology allows us to do that. Now, the good thing about that is there's so much in terms of recovery, invasiveness, and health benefits less bleeding time, less stretching, less trauma, less fatigue, less anesthesia time, and then things that you have no catheter, no nasogastric tube that's left in. There's a lot of invasive things that we just chalk up as normal for a long procedure that we don't have to do now. So it's not a race. It's not like we can do this faster as a bragging right. It's that technology allows us to skip steps like wiring, unwiring, measuring, bending, and do the operation quicker and also more efficient. To get these better things.
So on that point, so Brian Hockel, he's a well-known airway dentist who just underwent an MMA a year ago. He just posted his post-surgical results. He had a nice big advancement. I think it was with Dr. Reza Movahed, and I commented, "Hey, nice looking advancement, good for you." And then I said, and by the way, I can appreciate that because I just witnessed Dr. Alfi do 3 MMAs on Monday.
Right.
I'm here in Houston hanging out with Dr. Alfi, shadowing him, learning about his surgical technique. I watched him do 3 MMAs on Monday. And he said, he responded on Facebook, 3 on Monday. And I said, yeah, the custom plates allows him to do this surgery much quicker. In the operatory next door, the gentleman had completed 1 surgery in the time that Dr. Alfi did 3 triples.
Right.
That's double jaw plus genio.
Right.
And then he said, I'd rather my surgeon not rush. I want my surgeon to take my time.
Right.
This is a common response you get when you share your workflow with people, or you're at least tell them that you're doing 3 surgeries a day instead of 1.
Right.
How would you respond to that? Are you rushing? Is it actually a bad thing?
Yeah.
That you're doing this surgery much faster and have a lot more volume?
Right. So my response is first of all, it's something that I completely understand, the criticism and disbelief, because you're talking about legends in the field have been doing this their entire careers, and I can do the operation, like we said, 5 to 8 times faster. It sounds crazy.
It's unbelievable.
It's unbelievable. It's hard to believe. So I don't take that for granted, that these criticisms come from a reality where it's just hard to believe that something can be done this way. Right. So when it's hard to believe, the default thought is going to be there's something wrong.
Yeah.
Right. Is it rushing? Now the reality, you've been in the operation, you've seen 4 of them this week, right? And you can attest that there's nothing being rushed at all. In fact, it's very thorough and clean, and probably have more steps and products than most surgeons add to their procedure.
Totally.
It's actually more thorough.
And just to comment on that, in the operatory, it feels like everyone on the whole floor sort of hovers in and out and is just like, oh, it's Dr. Alfi. Wow, he's already on the lower. It's only been 30 minutes.
Right.
And people come in and sort of, almost in awe. Yeah. And because on the same floor, there's other surgeons doing traditional jaw surgery, and they're not coming in and saying, oh, this is sloppy or he's rushing. They're coming in awe of this completely radically different process that is really, it's a paradigm shift.
It's a paradigm
compared to what they're used to seeing.
Exactly. So I understand. And anyone that really knows orthognathic surgery, surgeons know this well, it's an impossible operation to rush, actually, because there's so many things that have to happen and happen right to get from A to B to C to D to Z, the final outcome. So it's something that is impossible to make the right cuts, the right fixation, the right splits, the right position to get the right bite at the end of the day. It's impossible.
Like if you rush an early part of the procedure, you're just screwing yourself over for later, basically, because each part depends on the one before it.
So if you rush, you'll be there for 10 hours because you won't get past a bad split or a bad position of the upper jaw where now the lower jaw is off, and then you got to troubleshoot it. It's impossible to rush. It's impossible.
Right. Before you mentioned height as being one thing that custom helps you get right.
Right.
During the surgery, it took me 4 surgeries to understand it.
Yeah.
But you kept insisting that this is really where custom shines, is in preventing TMJ problems from occurring. with the plating of the mandible.
Yep.
And you said, okay, you see this right here, you see how this plate is in the same plane as the mandible.
Yep.
This is good. We're sure that we're going to get a healthy TMJ because of this custom plate telling us, giving us this information, acting as a GPS on this ramus to guide us and make sure that the condyle is properly seated. Could you maybe like explain in technical terms how custom prevents
what
TMJs, TMJ issues from arising post-surgery?
Yep, and I'm glad that it's not a mystery to you anymore either, right? This is something that you were able to understand from seeing it. So traditionally, and you know, TMJs can worsen after jaw surgery, after orthognathic surgery. There's concerns for that, especially people that have predisposed TMJ issues. They were even more at risk to developing more issues after surgery is a big issue. So there's, you know, like a hesitancy to make large movements, even use a BSSO. And some of these people, there's something that we used to do called a condylectomy or IVRO and intraoral vertical ramus osteotomy, where we just cut down straight. Where we just cut down straight here and then wire the mouth shut and not even put a plate to just leave the condyle hanging in people that were at risk for TMJ problems. So there was an issue in that, and we didn't really understand why that was. And I didn't really understand it until I transitioned to the custom, and I got information from the custom plates that told me what was happening pre-custom, and I'll explain it, and what's happening now with custom. So when you make a sagittal split osteotomy, that's what we call the cut in the lower jaw. So the cut goes from inside the lower jaw, right here, inside the lower jaw, down obliquely, and then here. So you have these two segments that are split, and now this segment can telescope in any way. In the surgery, now this segment is free from this, right? And the surgeon is taking a plate, bending it, conforming it, and plating from here to here once the mouth is wired shut. Now, when they're doing that, this part of the jaw, the back part of the free segment, we call it the proximal segment. It's a segment that holds the condyle or the TMJ. Mm-hmm. There's no way to really know if it's torqued this way or that way or that way.
Right, torqued out toward the ear.
Correct.
Or flayed
this
out.
segment right here can be like that, like that, like that, and then we can just plate it in any direction. We can plate it torqued in, we can plate it torqued out, and it's blind because you're just looking over here. There's no way to know what's happening. So even if it's a millimeter difference, if there's some bone interference and it's preventing it from coming to the right place, you don't know that because it's just all the information's only at the teeth level.
And just because I take it for granted that I know what you mean by torque because, you know, I've been with you all week. But torque, like if imagine an MSDO surgery where you're splitting the mandible here and then
torquing out,
expanding it
like
at the midline.
Opening a book.
Yes, exactly.
Right.
Opening the book, Pac-Manning the mandible, basically.
And then what happens is that pivot point is going to rotate. That's the condyle. If you look at my thumb, it's the condyle. You can plate it here, you can plate it there, and it's going to put different forces on that TMJ. There's muscles and ligaments attached to it, and if you rotate it too much one way or the other, inappropriately or unknowingly, we're going to get damage on that TMJ. And that's not something that anyone really can appreciate until they do a custom case. Because with custom, the plate, as you can see here, is flush with the bone in the correct position. So when we plan it, we can plan it with the TMJ neutral in the right position. And when I put the plate on the proximal segment and I line it to the distal segment, if it's flush on both segments, I know that these are behaving the same way as they behave on the plan.
Right. On the plan, you plan for TMJ health.
Plan for TMJ health, yep.
And the plate forces you to preserve that plan.
Right.
Specifically in this dimension of being flush with on both sides.
Specifically in that dimension, because if you put it and it's flush on the back, but it's a little raised in the front, it's a millimeter or two off the bone, but it's seated, the bone is seated because there's interference in between the segments, but it's not letting that plate sit all the way, that means that this is torqued.
Right.
And there's no way you would know that if you were just plating it, because you would just take that seated position and plate it.
Right. There's no measurement that
It's
you,
impossible.
even with traditional, there's no
impossible.
ruler.
There's
that you
nothing that can tell you.
and you didn't even realize, like,
I didn't realize that until I started understanding and using custom, because then now I know that it's pretty often where you put it and it's a millimeter off, and I'll know that I'm not ready to plate it. Because if I plate it, I'm just going to rotate that condyle. I could plate it, but I'm going to rotate that condyle. It's not going to be healthy. So instead, I'll look at the plan again. We usually have illustrations to know where to anticipate some interferences, some early premature bone contact, and I could relieve that bone and then get to where I planned.
right. Yeah, that's, and that sort of speaks to the unpredictability of developing TMJ disorders after surgery.
Correct.
It's almost like the surgeons didn't even know what they were doing.
And a lot of them still don't really understand that unless they really start doing the procedure this way. Then it's like a light bulb, like, look at all this information I have now. I was for sure torquing those condyles, not knowing it. And that explains why some people had some unpredictable, unfavorable results with their joints after surgery. Now, instead, we're seeing an entire paradigm shift and even philosophy where TMJs become healthier consistently and predictably after surgery.
Yeah.
So in fact, a lot of my patients come to the office not for even thinking about jaw surgery, but just complaining of their TMJs. And in the past, or in any other office in this world, the TMJs would be looked at and targeted for treatment, either an injection, steroid injections, trying to move the disc back or forth, even replacing the joints themselves without actually thinking, why are the joints hurt in the first place? It's usually secondary to something that's primary. And most of the time, what's primary is a bad bite, bad mechanics, and a bad airway. Because a bad airway is really endemic. I mean, almost everybody in the last 500 years developed a bad airway. Our jaws are too small. So it's so common. It actually should be something that we rule out. Does someone not have a bad airway? Right? Because what we know from anthropology and studies is that people have small jaws compared to what we had 500 plus years ago for thousands and thousands of years. But, everyone looks at faces in the present. And even if you look at historical faces from ancestry, we're talking about 5 generations. We're only looking back several hundred years. And even though we think it's historic, it's a little timestamp in the history of man.
Fingernail.
It's a fingernail, right?
Yeah.
So it's like if you zoom out and the evidence is there, it's not controversial at all. This stuff's been documented, studied, accepted for hundreds of years. Major institutions, Stanford, Harvard, not only the US, but in Asia, Europe. There's evidence that the skulls 500 plus years ago, pre-industrial and agricultural revolutions, that there were changes in the facial development.
Yeah,
the faces are shrinking. They're getting smaller. So we know that, but what people still up until recently really never put together is what that means besides having smaller faces.
Besides an aesthetic difference.
Besides an aesthetic difference, and it's not an anecdotal difference. It's not just trivial. It has significant impact on our health, and we accept 90% of the population to need or not need or benefit from braces or orthodontics, right? Almost everyone had braces at some point in their life, and that's because they had crowding in their teeth. But why do people have crowding? They didn't have crowding 1,000 years ago. Not only they didn't have crowding 1,000 years ago, they even had room for 32 teeth to erupt. Mm-hmm. They had room for their wisdom teeth. Now we just kind of accept that everyone needs their wisdom teeth out, and that's fine. But we got to think about why is that, and was that always true? And the answer is no.
No, of course not.
Yeah.
Yeah, the wisdom teeth aren't vestigial organs.
Correct.
Right? They're not just a leftover from our evolutionary
Correct. It wasn't
past.
a mistake.
Yeah, it wasn't a mistake.
It wasn't a mistake. We were designed to have these teeth. We weren't designed to have limited room for them. Yeah. And it's not, and it goes past the teeth. It's not just the teeth that are become a problem that we need braces for. We need to remove teeth. But then what does it happen? What happens to the nasal passages, which sit on the upper jawbone? how many people end up going for a septoplasty, turbinectomy, rhinoplasty to breathe better through their nose, thinking it's a nose problem, when what we really understand is it's a jaw problem. The jaws are recessed, narrow, so the internal nasal structures that are sitting on that jawbone are confined, restricted, and
they get compressed.
And they get compressed, and people are getting the wrong procedures.
Right.
Because
so a deviated septum, if the palate is narrow, that means it sort of grows up high and vaulted, and that kinks the septum. Is that what's going on?
Correct. Yep. The septum has no room, so it buckles. Then the turbinates, and then that buckling of the septum restricts airflow on one side or both, because oftentimes that buckle is an S curve of the septum. And then the turbinates have limited room. So I think what's going to happen is there's more surgeons like me in the future that are treating these things and doing a good job with jaw surgery. That's going to be the go-to for any breathing abnormalities. And that's the ultimate aesthetic and functional operation if it's done well. And I think that will be the truth in 5 years time. And it's the tongue space too.
Yeah, it's kind of a radical thing to take someone that presents with TMJ disorder and some sleep disordered breathing, or maybe even something more general like brain fog or chronic fatigue, ADHD, or any other symptom of sleep disordered breathing, and just sort of say, hey, jaw surgery could be something that could make you feel more optimal, especially because this surgery has a reputation of being so brutal with terrible recovery times, et cetera, et cetera. But I think you're a little bit more liberal in the patients that you're willing to take on as candidates for double jaw. Is that true? And where does that come from? Like, how do you approach your judging whether someone's a candidate as compared to a more traditional person who's straight out of academia?
Yeah, I mean, I think that's true. It's true for me in particular. If you take my career for an example, when I love jaw surgery. It was my passion coming out of residency at Columbia University, and I came straight here and developed the practice specific to orthognathic surgery. But up until 6 years ago, when I transitioned to fully customized workflow, it was a 6-hour operation, 4 to 6 hour operation, and people had a lot of elastics post-operative. The results were not as predictable. The TMJs was not as predictable. The recoveries were difficult from these long operations. And it was something that we would really try to reserve for the most desperate patients for those reasons. And it was something that I would talk patients out of. And a lot of jaw surgeons do that still. Because of the reality is that it was a very difficult, unpredictable surgery. But it's changed. Now I consistently can do a surgery in an hour that's not just faster and has all the benefits of a faster operation, but it's way more predictable, way more stable. The TMJs respond a lot better. So it's something that, of course, it's a large operation, but something that's has a completely different recovery than it had historically, and more predictable, stable results. Where the risk benefit of doing it is much in favor of benefit versus risk, where it's become now a great operation to recommend. So what that's done in my career alone has changed who I would recommend this operation to. This next year I'll probably operate on both my brothers now on something I completely recommend to them, and something that they're interested to get done. So completely different. And I operate on patients now that traditionally I would think that the benefit risk ratio was not in their favor, and I would try to talk them out of it. But now these patients benefit tremendously. They come with chief complaint is just TMJ pain or jaw pain or neck pain or shoulder pain, or they don't really snore, but they're tired, or they have headaches, and these things get much better.
Yeah. When the cure is not as bad as the disease, or when the side effects are not so intense, essentially it's become more of an over-the-counter medicine than a prescription medicine, because the stakes are a lot lower.
Correct. Yeah, correct.
Yeah, people don't really associate the shorter surgery times with better patient outcomes, but that's also a huge part of it, because I watched you do several surgeries this week, and there is a certain amount of wrestling around with the tissue that occurs, especially when you're, getting toward the back on the upper and the lower. Things have to sort of get wrestled open and held open, and nerves get sort of pushed around a little bit as plates are fitted, et cetera,
Right.
et cetera. And I can see how coming out of that, there's going to be some
swelling,
numbness,
discomfort.
some swelling, discomfort, pain, et cetera, et cetera. It's a tough process, but I can
Right.
see that times 7.
Correct.
And I'm just like, holy crap,
Yeah.
I get why
Yeah.
people are wrapped in a bandage
Yeah.
for extended period.
That's exactly what it is. It's that times 7.
Yeah,
or
right.
in this case, divided by 7.
Right. And instead with the custom plates method of doing double jaw surgery, your method of doing double jaw surgery, you're getting, and this is what you've been telling patients all week, one really tough week, one
Right.
week that sucks.
Yeah, that's what I like to say. I said the first week sucks.
But after
Anticipate it. Yeah.
after the first week, you have people going back to school, going back to work,
Yep.
definitely after 2 weeks.
Definitely. Yeah. And you saw some recoveries at different time points, and many of them will say I had 0 pain, or I had minimal pain, or the pain ended after 1 week.
Right.
And it wasn't as bad of a recovery as I expected.
I've heard some people say this week, I had no pain, I just had discomfort.
Right.
Yeah, but of course, regardless of whether it's custom plates or traditional, there's still 8 weeks no chewing,
Correct.
8 weeks of soft, mushy foods.
Yep.
There's no way around that.
Yeah. Not yet. Not yet.
But, because another problem with jaw surgery is that people might want to do it, but how do you carve out 6 weeks out of your life? Not everyone can just take a sabbatical where they can
Yeah.
sit in a room and recover from jaw surgery.
Yeah, that's not what we want them to do, actually. I want people getting back to normal life as soon as possible.
Yeah.
And usually that's 2 weeks to get back into the work field, into the office. Even exercising, I encourage exercising at the end of 1 week. But the more active people are and back to normal life, I think it has a positive impact on healing. And now the realities of the operation, that's become a reality of the recoveries. Now the non-chew diet, thankfully nowadays, I have a nutritionist in the office that has made a huge impact for our patients, and she'll sit with our patients and come up with a plan to make sure they're nourished and supplemented, and they enjoy the process of becoming healthier as well and eating cleaner.
Right.
And get ideas for non-chew diet. And it's not there's confusion. A lot of people think it's going to be a pure liquid diet, and that's not the case. It's just a non-chew diet. So I don't have rubber bands on the patients after. They're not wired shut. They can open talk, put a spoon in their mouth. But it could be anything. They fork beans and guacamole and queso and eat it as long as they're not chewing. So people do okay.
But by the way, that's a big difference, though, what you just said about not being wired shut and being able to wake up and talk right away.
Yeah, right away.
With traditional, the way that the plates are, the surgery depends on sewing the mouth shut, essentially. And so it's kind of like you can imagine why people envision it as this horrible, barbaric process because their mouth is being wired shut.
I mean, that's a
they
terrible
wake
feeling.
up feeling God knows how they feel, and then they can't even communicate.
Right.
But, I was sitting with Eric yesterday, and one of the first things he was sure to say was that he woke up, he was talking.
Right.
So that's a major difference.
It's a major difference, yeah, and a huge impact on the mental aspect of recovery. If it's like, hey, I'm, by the end of the week, I'm going to be back in the gym and lifting weights and on Zoom calls or on phone calls and doing some work. It's a completely different mind state than I can't go to the gym. I got to sit in my bed. I can't talk. I got to write down things. It's completely different for that, good recovery.
So when you make the surgery that much more accessible by making the recovery so much easier and the risk of TMJ disorder and botch in general so much less, that opens up the conversation of using this surgery more liberally, almost as like what we've been talking about all week, almost as like a biohacking tool.
Yeah, absolutely.
Can you talk about how you see jaw surgery as sort of the ultimate biohack, and maybe delve into what you were saying about like how it ties into Gary Brecka's philosophy about metabolism and how health starts there?
Yeah, absolutely. So, I'm into biohacking. I think it's fascinating. We all want to be the best version of ourselves, the Mamba mentality, the best version of ourselves, which means healthy, happy, good mindset. So those things, meditating, grounding, eating clean, exercising, cold exposure, hot exposure. These are amazing things. Supplementing at the cellular level to make sure that the cells are optimized are amazing things for well-being and productivity and anti-aging. And that's something that I think everybody is interested in.
No doubt.
You know, since the beginning of mankind, everybody wanted to preserve youth and wellness and health. So that's what biohacking in general encompasses. And I think that now we have an operation that is the ultimate biohacking tool, because if you think about, you know, Gary Brecka, for example, and human biologists like himself who advocate for cellular optimization. So people that have mineral and vitamin deficiencies and their cells can't behave appropriately, so their hormones are not producing appropriately, there's imbalances, and then that affects down the stream the well-being of the person. You know, if you think about testosterone, for example, testosterone is in man and woman, and besides the primary secondary characteristics of what testosterone gives us for hair growth or balding or Adam apple development and all these things, is its function in telling the bone marrow to produce red blood cells, erythropoietin, right? So it's really important in red blood cell development, and that what red blood cells do is carry oxygen to the tissue. So ultimately, everything we want to do at the cellular level is to make sure down the stream that our cells are getting oxygen to function appropriately.
Right.
And there's only one cause of death. The only cause of death ultimately is the cessation of oxygen. That's the only cause of death. No matter what the death was, whether it was a gunshot or a fall from a building or a heart attack, what actually results in arrest is lack of oxygen, right? So that's the primary vital process.
Right.
Is delivery, right? A heart attack is ischemia or lack of oxygen to a heart muscle. So getting good red blood cells and oxygen delivery to the system is biohacking in essence at a level. Now, you can do all that, but if your jaws are structurally limiting you from getting great oxygen flow and good sleep, we talk about sleep hygiene as a big biohacking tool, right? Going to sleep early, making sure you get 8 hours if you can, and getting deep sleep or REM sleep and all these things.
All the biohackers rave about sleep.
100%.
And it's the one that they can all never figure out.
Yeah.
So many of these guys have perfect regimens, but then they're like, but my sleep is still kind of like, it's okay, I guess.
Exactly.
I still got to figure that out.
Because you can do all those things, but you can't, if there's a structural problem, which we know that for the last 500 years, that's everybody, right?
Yeah.
Almost everybody has a structural problem. There's going to be a disruption in good sleep and a disruption of oxygen. And in a biohacking tool, you can do everything from the bottom up. You can give soils nutrients, but if you have no sunshine or oxygen from the top, then you're at a standstill. You're not optimized. So biohacking in essence, I think of it as a tool. You need both. You need all of it. You need good habits, you need clean eating, you need cellular health, but at the same time, you need to get good oxygen and good sleep. And this is an operation that is really the best tool for that.
Yeah. Yeah. The oxygen intake is the most neglected part of the larger biohacking community.
Right.
Which is weird because like the human bodies are very similar to like combustion engine in vehicles. And if a car isn't functioning well, a mechanic who might not even have a college education knows to check just a few things, fuel, air, and spark. Right. It's one of those three things that's causing the car not to function properly.
Right.
It's almost like cars have their own sort of metabolism, right? And they're, the concept of making sure that the air intake is correct for a mechanic is routine.
Right.
It's common sense.
Common sense.
And yet in the medical community, people will have these big bodies in these tiny little air intakes. It's like It's like
right, exactly. That's
we're
a great
walking
example.
around with
Great analogy.
Ford F-150s engines, but some people will have a Mini Cooper air intake on that.
Right.
And it's like,
Right.
what do you get?
What do you get?
You get sort of a pickup truck functionality,
Yeah.
but at the end
That's
of the day,
something that's going to crash.
it's going to crash.
Yeah.
Yeah. And so, my channel obviously is very highly focused on, addressing the air intake problem. And then it's like, well, is jaw surgery the ultimate when it comes to jaw hacking too?
Yeah.
And when you see the way that you do surgery so precisely, so quickly, and with such little recovery and low risk of botch, it brings into question this, like, the age-old question of, is MARPE necessary? Right? Because remember, most people who watch my channel, they're looking to take some sort of action to address their air intake problem.
Right.
And essentially the crossroads that everyone has arrived at is, do I do jaw surgery or do I do some sort of skeletal expander?
Right.
Or do I do both?
Right.
Now, you have held a contrarian view on that I have personally pushed back against before I saw what you do in action this week. I've always said, for people that struggle with nasal breathing, you should definitely consider a MARPE first.
Right.
Because the MARPE does transverse expansion on the palate,
Right.
opens up the nasal floor.
Yep.
Supposedly that flows upstream on the y-axis to the whole nasal
Right.
volume, can improve nasal breathing. Jaw surgery advances the jaws,
Right.
for the most part.
Yep.
But what are your thoughts on jaw surgery as it pertains to nasal breathing, the role of MARPE in addressing air intake, and how jaw surgery can replicate or replace what MARPE does, albeit in a slightly different way, with that procedure that you do where you shave at the base of the nose, and take a millimeter or two of bone right off to open up the nose.
Yeah. Yeah. So it's a great question, and something that, I think protocols are evolving now with this, because if you look at, back to, is jaw surgery the ultimate tool for this airway issue? The answer is yes. Because if you think about every other tool there is to increase, they're all trying to accomplish a bigger airway. The problem is all these other tools accomplish them in very limited dimensions. For example, a MARPE will do it in a transverse dimension, right? So, but if there's a transverse, meaning widening, but if there's a backwards forwards problem, it's not really going to address that. You can never expand enough to solve a backwards problem. You need to come forward, right? Traditionally, there were things called UPPP or palatoplasty, where surgeons would remove soft tissue from the palate or around the throat, or maybe even the base of tongue reduction, to try to eliminate these bottlenecks that from the soft tissue. There's something called Inspire, where people use an electrical impulse to move the tongue forward by pushing a button like a garage door opener, and it pushes the tongue forward. There's appliances that people wear to push their lower jaw forward when they sleep. All these are trying to target, certain different aspects, but not getting all of them together.
Right.
What jaw surgery can do is it can do every single one of them at the same time. And most people have a component of multi-level problems because the jaws are small.
Right.
Right. So it's the only way to really attack all of them.
And I guess that's the crux of what I'm asking is, can jaw surgery really accomplish all that a well-executed MARPE can accomplish? Or do you think that it can get like an 80% as good result for 20% of the effort? Is it a value proposition?
Yeah, I think that a well-done jaw surgery with or without expansion can do way more than a MARPE can ever do. I think it's the opposite.
But I guess that's not really what I'm asking. I guess what I'm asking is, what's the percent cure of jaw surgery alone versus jaw surgery plus a well-executed MARPE?
Yeah, so it depends on what the person needs. If someone is narrow And moving them forward, they're still going to be problematically narrow, and their bite might be in a cross bite, for example, or their nasal passages are too narrow. We may call for expansion either with MARPE pre-surgery, or I can just do a segmental, move the maxilla wide as I bring it forward in one piece. So I think that if someone will benefit from expansion, then MARPE is a good tool for it, but so is the option of just doing it at the time of jaw surgery, which for many cases, I think there's a lot of advantages to doing that. Now, I still do cases with a lot of providers where we will set up the case with a MARPE first and then make the surgery a little easier by bringing it forward.
Well, is that the one benefit of MARPE, is that it simplifies surgery and lowers risk, or is there something else to...
Yeah, I think that's one benefit, but the risk is not really different because there's risk to the expansion of the MARPE itself. And doing, whether you get that risk separately or before or at the time of expansion, I don't really think there's a big risk difference between MARPE and expansion the way we can do it now. I think that and in terms of surgery, it does make the surgery easier from not having to expand it, but we're talking about 20 minutes of time for this.
Right. Is the patient recovery different in a 3-piece segmental versus a 1-piece?
Not usually. Not so much. There's a little increased added risk to it, but same with the MARPE itself.
What's the risk? Risk of what?
Yeah, risk of damage to the teeth. Same as with MARPE, you got to split between teeth to expand it. So people have had problems with the roots or teeth that are in the way of the split. Thankfully, it's rare, but it is an added risk, either with expansion or with a MARPE. With the MARPE, there's risk of asymmetric expansion. Now, if someone's going to get surgery afterwards, we can usually fix that with jaw surgery. But it depends where that asymmetry is. Sometimes you can't fix all of it.
What do you mean
very well?
That?
If the fracture happens up here and now you have a zygoma that's wider on one side versus the other, which can happen with a MARPE, sometimes that's going to be difficult to bring all the way back.
Have you seen cases like that?
Yeah, absolutely.
Yeah. And Dr. Ting was telling me that sometimes MARPE causes an asymmetry at the frontal maxillary suture, it'll cause one side to crack right here and not on the other side, and then the whole shit will just drop on one side.
Yeah, definitely. And we see these things commonly. I think the amount of asymmetries in an expander are happen in greater than 50% of cases. So it's not a totally risk-free thing.
Not by any means. Anyone who watches my channel knows that.
Yeah,
for sure.
Exactly. Where expansion is more controlled, really.
Expansion
surgically. Yeah, because with the custom plates and virtual planning, we can pretty much guide the cuts in between roots, and then plan for the expansion. It's just a little technically, and there is a learning curve for surgeons to get there, and you have to be good to do it predictably and stably, but it's definitely, once you have that, I think it's the way to go. Now, I will work with many providers that favor MARPE beforehand. I don't have a problem with it because I know that if they haven't expanded arches and developed arches for surgery, it does make my job easier. A straightforward operation, and I can usually fix most asymmetries and get the bite right. So at the current moment, in terms of protocols, the way I think it makes sense is if somebody needs time to prepare for surgery, meaning their lower arch also needs to be expanded with maybe SFOT and orthodontics, and there's some crowding that needs to be dealt with, and it's going to take 6 months to a year to get someone ready, and they need an expansion, it makes sense to me to go through the MARPE at that time. Yeah. Because you need the time to prepare anyways, and why not get that expansion and prepare it and make the surgery easier. Now, if someone's pretty much ready for surgery and doing a MARPE is going to really delay their case and add all this extra turning and recovery and a gap and closing the gap, to me, it makes sense just to do a segmental and go to surgery faster, do the expansion and get them where they want to be. The point about nasal breathing is a non-point for me, because I know that I can get better airflow with the Lafort procedure and the way we can free up bone in the floor of the nose, and as good as any MARPE or type of procedure can do. And you saw that, and you saw what the patients say afterwards in terms of nasal airflow.
Yeah.
And the way we do that is, if you look at the floor of the nose, once the upper jaw comes forward here, there's a lot of excess bone here, bony spurs. There's a vomer bone that sticks up here, and a lot of people have this extra bone on the floor of the nose, and a lot of these patients have narrow bony nasal passages. And I have control of that at the time. We're right there in surgery, so I do a maneuver where I clear excess bone and make sure that the turbinates and septums have a lot of room to sit, so airflow is not a problem. We can get a tremendous amount of airflow with that maneuver. So the MARPE just for nasal airflow is not something that I would prescribe, because I can get that with jaw surgery itself, with or without an expansion.
Now, how would you compare the benefit that you get from that with, like, take Dr. Casey Lee's ease, for example, where supposedly the posterior reverse conical expansion of that flows up high into the nose at the back of the nose, whereas what you're doing is more at the front of the nose. Is it still theoretically possible that combining those two things together gives you a better overall improvement in your nasal breathing? Yeah,
we can get it all the way posterior, because if you can see the vomer, we get it all the way back to the posterior nasal spine, and I'm clearing bone not only in the front, but I'm clearing it all the way in the back. And most of these patients, if they need expansion posteriorly, I'm going to do that at the time with a segmental or prescribe a MARPE, either way. But it's not something that you need to combine that for that reason. Another thing that happens, as you see, is most of these patients need a counterclockwise movement.
Yeah.
And what a counterclockwise does is it brings the back of the upper jaw down.
Right.
Because it's doing this. So the back comes down. So that posterior nasal area clears up tremendously from that movement.
Right. And that's the explanation of how double jaw surgery opens up nasal breathing, even if you don't cut the bone in the front.
Right.
Is that right?
Yeah, if it'll help in the back for sure. Yeah, but I think it's important to get it in the front, because any bottleneck is a bottleneck. Right.
Now, anytime you do a 3-piece segmental, though, isn't there going to be some dental expansion or some kind of expansion that's required on the mandible, or is that not necessarily the case?
Not necessarily the case. A lot of people relatively are more narrow on their upper jaw than their lower jaw.
Right.
So
is the lower jaw always limiting how far you can go with the segmental and the transverse?
In a way, yes, but usually what happens is when the jaws are narrow, it's very rare that the base of the mandible is narrow. It's usually the teeth that are tipped in, and that's something that could be corrected orthodontically. So usually the lower jaw is not a limiting factor. It's just something that needs to be worked on, because it's extremely rare that the entire jaw is narrow. It's usually, this is the case, that the base of the jaw is wide enough and the teeth are tipped in to match the narrow upper jaw. So when you expand the upper jaw, even in cases where the lower jaw is narrow, working with a good orthodontist, with or without SFOT if needed. SFOT is preparing more bone so the orthodontist can tip those teeth out if there's no bone on the outside of them. But in a lot of cases, they don't even need that. They can just tip them out and then either use a MARPE to expand the upper jaw, or we just expand the upper jaw at the time of surgery to match the lower jaw.
Interesting. Okay, I want to also ask you about surgical planning. Yeah, could just press the red button on top and see if that starts it up again. So we just had a little technical difficulty, but it's all straightened out. Before we get off the question of MARPE, I'm thinking back to my interview with Casey Lee, and a good friend of mine made me promise that I would pose these two things to you. Casey Lee, who also does orthognathic surgery, but also famously does the ease, and that's his sort of pet MARPE procedure. He said the limits of segmental, 3-piece segmental, are the skin at the roof of the mouth, number one, and the fact that when you do the segmental, you essentially bump into the zygomas because of something about widening the maxilla, and then you hit the sort of the zygomatic root area, which limits the amount of expansion you can get with that.
I mean, I haven't found that in my experience, and I do a lot of segmentals over the last 10 years to 12 years. That bone in the zygoma I can usually account for, especially in the virtual planning. Like you saw it, we can mark out interferences, right, and just remove any bony interferences. So that never really, I can't think of a time where that was a limiting factor. Now the soft tissues, they need to be stretched sometimes, but there are some technical aspects to be able to stretch that. So usually the amount that people would need for an expansion, unless they need a really tremendous amount, but usually you're talking up to about 1 centimeter of expansion, maybe even a little more, can be done safely if it's executed well with a segmental.
Right.
You know, I've had cases where they're really V-shaped and the lateral incisors are completely blocked behind the central incisors, and those are cases I'll want to expand first with a SARPE or a MARPE. But those are rare.
Yeah. So those I'm sorry, I missed that. Rare. Why are those better suited for MARPE or SARPE?
It's just, they're so narrow, and these are extremely rare deformities that, you know, they're going to need 15 millimeters of expansion or more, which is rare. And in those cases, I don't feel comfortable expanding that much. So we'll do it first with the slower, safer in the sense that it's slower.
And slower is better, or slower allows you to get a greater magnitude expansion with respect to the skin at the roof of the mouth. Yep. And with respect to, it takes the zygomas with it. And so you don't have to remove interferences there.
Even with those cases with a SARPE, without relieving bone there, the zygomas could be a problem. So even when I do SARPEs, I'll make space in the zygomatic area to account for that expansion. Otherwise, that could be a problem. So it's the opposite. If you need a good expansion, sometimes you actually have to go there and in a surgical assisted way remove some bone interference. But really, it's just if someone needs around 10 or less, which is most people, like I'm talking about 99% of people that need expansion, we're looking at 10 or less. That can be done predictably with a segmental. If someone really needs like 15 or more, I might want to distract them first.
Right. What about the people who say, and I'm one of these people, I have been at least, who say that MARPE is great for cheekbone enhancement, and that's a good thing to do before jaw surgery, because when you advance the lower third, you do a double jaw, genio, now you're enhancing the lower part of the face and your cheekbones are left behind and you end up with the dog face.
Yeah. I mean, if you look at my before and afters, and I have hundreds of them on there, almost all of these are done with jaw surgery.
Only. You're not doing cheekbone implants.
Never.
A la Raffaini. I don't even know if Raffaini does that, by the way. He might not.
No, I mean, I could do them. They're easy to do, but they're never really warranted, because you can see here, for example, when this jaw is advanced, and especially if you cut high enough at the root of the zygoma, this, you know, the eye is right here, right? The eye is right here. So this area resembles the cheekbone. So as this comes forward, it also has a widening effect. It makes the cheekbone stronger and wider just from that telescoping procedure you can see here. So if the advancement is enough, and usually it's going to be appropriate, right? If someone is deficient in the cheekbones, they're going to usually be deficient in the midface, so they're going to require a larger appropriate movement. But that movement, you can see here, will always enhance and widen the cheekbones. And if you look at the before and afters, I mean, make your opinion on that, what you think about.
They speak for themselves.
They speak for themselves, yeah.
So, but you showed me earlier in the week, because I kept pressing you on this. Yep. Can you hold up the skull if you would?
Yep.
And so essentially, as you do the Lefort and you advance the maxilla, right? And it's being held forward in that advanced position by the plate. And now you've created this little cliff area.
Yep. This step right here.
The step, correct. Better word for it. And then you stuff that with grafting material.
I put bone graft there, yeah.
And when that heals,
it's no longer a real step. It's now a confluent.
A mound almost.
Mound. Yeah, it's a confluent jaw that now has a 10 that's wider.
Right.
Yeah.
Right. Are cheekbone implants ever necessary post-jaw surgery?
I think for some people that have, strange, really rare craniofacial syndromes where they really, really malar deficient. But again, these are extremely rare. This is not what we're talking about.
Did you say malar deficient?
Yeah.
What does that mean?
This area we call the malar.
Okay.
Cheekbone. And, there's some craniofacial syndromes where they're really, really deficient, but these are extremely rare,
Genetic conditions, not just like wasn't breastfed.
Correct.
Did ate something.
Correct.
Like, this is a whole
these
different
are
thing.
like autosomal dominant craniofacial syndromes like Treacher's-Collins. And these are usually seen in a children's hospital and taken care of earlier with a team. They have cleft lips and palates. It's a different subset population. The majority of patients that are deficient from their jaws, and fixing them appropriately with jaw surgery will enhance the midface appropriately.
Right. Just for the record, I saw you do some genioplasties where you actually cut the tip of the chin off, plate it forward with custom plates. Is that how a cheekbone implant in a case like that would work? Are you actually slicing the cheekbone and then moving it? How does it work?
The implants are actually just veneers. They're basically either some kind of plastic or metal that are placed on it so that the tissue, kind of like a breast implant.
But not silicone?
Could be silicone. I don't think those are popular.
Yeah,
anymore.
some implants are better than others.
Yep.
Hard implants are better than softer implants.
I think if I were to do it, if someone really needs one, and I'm telling you the indication for it, I don't see, and I see 1,000 consults a year.
Right.
They're extremely rare. But if someone, when the time comes that I think someone will benefit from it, maybe a traumatic defect where they completely lost something.
Yeah.
I will make a titanium custom designed metal implant.
Oh, incredible.
Yeah, and you can make a very thin mesh, and I could put bone underneath it so that in the best case, the bone will actually conform to that, so the metal is not even needed with time. But even if the bone doesn't heal, the implant itself will provide the structure. I think that's, with technology now, I think that's the preferred way to implant. But we're talking about real traumatic defects, rare craniofacial syndromes that I think require these things. Otherwise, I think that the traditional custom jaw surgery is going to make people much better. And, look at the work itself.
Yeah.
And make up your mind. But in my experience, that's what I believe.
Yeah. While we're up in that area, I want to talk about bags under eyes.
Yeah.
Something interesting happened this week where a patient came in and they said, "Oh, how will this affect my, the bags under my eyes?" Those have a name, right? You called it something. Is that a condition or something? I forget what it was, but you said basically that gets better with better sleep.
Yeah.
Is that your opinion? Is that not about bone deficiency? That's more about an endemic thing?
Could be a little bit of both, but we know, anyone that goes a day or two with bad sleep, they're going to have deep bags under their eyes. So there's no doubt that better sleep is better for that tissue over there. Mm-hmm. And then some people may have a structural problem too with the midface where they just have lack support there. So I think it's a combination. When that midface gets better with that Lefort surgery, plus they get better sleep, those almost always get better. You saw it with Eric right away. It's something you noticed. True. Yeah, but we'll see it all the time. And you look at the before and afters, people's that structure, those eye bags get better. Yeah. After surgery. And I think it's a combination of the structural support plus better oxygenation, better sleep.
Do you believe the eyes are the windows to the soul?
No doubt about that.
And so would that sort of tie into what you just said about curing the air, cures the soul, reflects in the apparent health of the eyes?
Absolutely. One of my favorite things to do when I look at people's photos before and after is I notice the eyes. And, as an exercise, go through before and afters of good jaw surgery. You look at my page and look at the before and after, and the eyes look so much more alive in every patient after surgery. And I think it has a lot to do Yeah, you're right. That oxygenation, that sleep, and that window.
Also, while we're on the eye area, I'm not sure if you're familiar with GiantImplants, the channel, and
I am. He's an Instagram friend of mine.
Oh, nice. Yeah, me too. I've never spoken with them, him. I don't know who it is. It might be a group, might be one mad scientist kid. I'm not sure. He could be a 17-year-old.
Right.
But he's doing this procedure. He's found some surgeon.
Yeah, somewhere in Turkey.
Somewhere in Turkey that's doing something to increase the interpupillary distance, modifying the orbitals, which are the bones around the eyes. What are your thoughts on that?
It's really interesting. I can appreciate the artistry behind it. I think that most people don't need that type of enhancement. I think it'll make an artificial appearance, a comic book figure.
You think so?
Really, for most people. I think people with some craniofacial syndromes, again, that have real deformities or traumatic deformity, that's a great tool to help someone become more normal. But for someone that has deficient jaws and an otherwise normal head, that's non-syndromic, non-traumatic, I think that's not the prescription.
Right. It's a Looksmaxxing thing.
Right.
GiantImplants is not even sure he thinks in terms of Airway.
I'm not sure. Yeah.
But while we're on that subject, what are your thoughts on Looksmaxxing and trying to build perfect faces from every theoretical cephalometric, angle, etc., the interpupillary distance? I think in general.
I think that people can be very attractive and good looking and look completely different. And, we know that if you look at Hollywood actresses and actors over years, there are so many different styles of faces and pupil distance, and even asymmetries where someone we would all agree is attractive or not. And we all agree that they're all attractive or not, or to a great consensus. So I think that individuality and customization is really important. And I think for most people, health is attractive and aesthetic. So you make people a healthy version of themselves. And for a lot of these people that their jaws are deficient, and making their jaws to an appropriate place where now they have a jaw structure, a jawline, and for their face, that's the healthiest they should be. I think that they're going to be the best version of themselves and an appropriate, attractive aesthetic outcome for them. I don't think there's a cookie cutter. Everyone should look like Superman or Batman face. I think that Penelope Cruz is pretty, and I think that Julia Roberts is pretty, and Nicole Kidman was pretty, all in very different ways.
Yep. And Adam Driver is attractive, even though he's got a non-traditional face. Or not textbook good-looking face.
Right.
Have you seen an influx in patients that have an unhealthy relationship with what they perceive to be how they're supposed to look, et cetera? It's these sort of so-called body dysmorphic patients.
For sure. We're seeing more and more of it. I think that obviously all this information leads into that, where it's, a lot of these patients, they have really good reasons that they want surgery. Most of them have bad airways. Most of them need better jaw structures. But I think for a subset of people, there is some inner work that needs to be done that's independent of actually the appropriate movements for themselves, that won't satisfy what they're looking for. I don't know if I articulate that appropriately enough. But I think that some people have an image of what they want to look like that may not be completely healthy or reasonable. And thankfully, I think this is rare, but this is a known phenomenon. Body dysmorphic issues have been prevalent and accepted in medicine for a long time, and it's very common in plastic surgery offices. So the tough thing is that almost all these patients, even when their thought process may not be completely mature or healthy, do have reasonable concerns that warrant an operation. The tricky part is distinguishing between what kind of reasonable outcome they're going to expect, because at the end of the day, as perfect as things can go for anyone, if in their perspective it's not what makes them happy, they're going to fixate on that.
Yeah.
And it doesn't matter how much healthier they are, if in their mind they're not, because they didn't get what they're expecting. Again, that's where it becomes a very difficult interplay. So
right.
I have a psychiatrist now in the office too, that I think is an important part of a holistic approach, because it's a big deal. A lot of these patients are dealing with a lot of issues. The jaws cause a lot of problems. Sleep is an issue. The social development over the early teenage years is affected by the aesthetic and functional problems that come up with. So there's a lot of things that stack on these patients by the time they get surgery, where it's more than just changing the facial structure. There's a lot of unpacking to do for a lot of people, and this is what we're trying to figure out is that this is a tool. Like we said, it's a biohacking tool to get people the best version of themselves, but it's not a one-stop going to fix everything in someone's life. It'll fix a lot of things, and it'll make people a lot better. But if we think of it as a biohacking tool where, I can breathe better, and now but I still have to work on my cellular health. I still got to meditate. I still got to eat clean. I still got to exercise and do everything I can. I think those are the people that are really going to flourish and see successful outcomes.
Yeah. Yeah. Right. It's almost like, could body dysmorphia almost be a symptom of sleep disordered breathing?
Yeah, it can be. I think there's a component of that, and I think the longer someone suffers for it, the more of that, let's call it baggage that needs to be unpacked has to happen. But I think that for sure, some people struggle.
Is there a protocol you have for managing expectations with the patient that you sense is maybe a little bit too preoccupied in the millimeters involved in the final metrics?
It's hard. It's something that comes with experience and managing a lot of different personalities and different expectations, but it's not always predictable. It's really hard to read into people, especially when they may not be communicating what they're really feeling. Mm-hmm. And it's sometimes hard to know exactly. I think the best thing we can do as surgeons and providers is give as much information as possible and give as much as we can to make expectations appropriate.
Yeah.
And then, provide as much support. Get a nutritionist. We build a team of the myofunctional therapists, get a psychiatrist on board. It takes a village for sure. We have a lot of really good providers that angle different, have different angles for a really holistic approach. And I think that they're very important together to get someone where they need to be.
Yeah, that's great. While we're on the subject of beauty and aesthetics, surgical planning is really where the donuts are made when it comes to how someone is going to look coming out the other end.
Yeah.
I have a client of mine in my airway patient advocacy work where I help people sort of navigate the field of choosing doctors and which treatments might be appropriate so they can then go out and get consultations with the right professional, et cetera.
Right.
He's doing the circuit right now, talking to different surgeons. He has one very prominent surgeon in Southern California suggesting a 7mm advancement of the mandible in accompanying maxillary rotation and advancement, and another one here in Texas suggesting 14mm.
Right.
That's double the move.
Yeah, it's amazing. The variation in treatment plans, it's real. I mean, it's true. It's true in dentistry. It's true in medicine. And even when there's in dentistry, there's millions of dentists, millions. Mm-hmm. And as as huge as that market is, you'll get completely different opinions and styles in a dentist. And then if you go down to a field like this where there's 5 to 10 of us that do this operation consistently in the country, you're going to get equally different variations in philosophies, skill levels, comfort levels, the tools that they use. So yeah, I mean, you're not going to find a standardized treatment plan. I think for patients, it becomes a very difficult thing, right? Because that's a huge difference, and it's going to be a huge different outcome whether you go 7 or 14.
Right.
It's going to mean a huge difference both in the aesthetic outcome, but also in the functional outcome. So I think for patients out there, it's important to have someone like you that knows the space and has a good understanding about what questions to ask, at least, so that the patient can make the most informed decision for themselves about what they're trying to accomplish, and making sure that plan makes sense to them.
Mm-hmm. So what is that difference of 7 millimeters? Is that a difference in aesthetic taste between surgeons? Does that one surgeon in Southern California just prefer softer faces, more moderate looking faces? Is his standard of beauty a more average face versus the surgeon in Texas maybe likes a more prognathic, a more sort of stereotypical masculine jaw?
Yeah, it's hard to say. I mean, I don't know the surgeons personally or their work well enough.
You can't read their mind, obviously.
Right, exactly. But I think that it's not that. I think it's much more complex than that. I think there's many reasons that's more than just the aesthetic taste, because I think that most people that have a reasonable experience and appreciation for anatomy and form, and I think most of us will agree on what looks good and what doesn't. I think that both those surgeons, if you show them faces of what they think is attractive and not attractive, will come up with very consistent results. I do believe that.
Meaning there's not a huge variation in
taste. Correct. I don't think so. I think that what it comes down to is, what is their philosophy on the function and the airway that may have something to do with it, and what is their comfort level with the movements. When I was using traditional plates, I would avoid larger movements.
Why? So, technically speaking,
the plates are weaker because you have to bend the plates in the operating room, and that deforms the plates and it makes them weak. So that's one component, is the rigidity of the fixation.
Don't you actually have some traditional plates here?
I do. So here's, for example, a Lafort plate. This is a tradition. It's not what I'm using now, but this is what I used 10 years ago.
Yeah, just the way you're holding it is perfect, right? By the way.
This is 10 years ago, and this is something that can easily be bent with my fingers, right? And then when you bend it with these pliers that I have here to get the form that you want, it's already weakened from this plate that I can weaken itself. So
it's like a paper clip. If you bend it enough times, it breaks.
Exactly. So I think that the older style plates are weaker, and that in itself poses a risk for larger movements that require more fixation. And then the other part of it is that the older technology doesn't really allow for a predictable, stable result or outcome compared to what a custom can do. So, for example, if you're making a large movement, like today we made a large movement, you can see there's a lot of...
It was 17
millimeters at the pagonion, right? With a large 8-degree counterclockwise rotation. There's a lot of tension in the tissues that without knowing the exact position and getting a passive place to it, if you're using without the information to get a passive position predictable and stable in the right place, and in combination for a weaker plates, you're at much greater risk of failing.
Mm-hmm.
Right? Of having relapse. We used to call it relapse.
Yeah.
I don't call it relapse anymore. I call it immediate, not what you wanted.
Right.
Right. But it was a limitation of the technology. And I think that until people really understand the custom workflow, it's not something that they can actually appreciate. You know, if you only were in an era where there were no cars, it's hard to appreciate that you can get to California in less than a week or 2 weeks, you know? So I think that people have to use the technology and understand it to start understanding the information that they were lacking before. So I think that even when I learned how to treatment plan, we learned to compromise the results. And for good reason. We don't want to hurt the patient, right?
Yeah.
We wanted to limit risk of relapse, instability, failures, non-healing, all these things. So you limit the movement. So I think that might have something to do with it, is the comfort level about where to go and the confidence that something's going to heal in the appropriate place or not. I think there's a lot of levels to it.
Yeah. The same surgeon in Southern California said that there would be essentially no airway difference between a 7 millimeter and a 14 millimeter advancement on the mandible. And that, and honestly, Anil Rama, in my interview with him, sort of reflected the same sentiment, which is that you never really know what kind of airway benefit you're going to get between a moderate and a more aggressive advancement. Would you agree with that assessment, or would you push back against that?
I definitely disagree with it. I think that more is more for the airway, for sure. And it makes all the sense in the world that the larger volume you have, space behind the tongue, space for the nasal passages, the less resistance you're going to have for airflow. I think this is just basic physics 101. I don't understand the other side of that statement at all, to be honest.
Certainly counterintuitive.
Yeah.
Could it be that, I mean, what you're saying is a 5-liter engine makes more power than a 2-liter engine,
right?
Which is like, duh.
Yeah.
But maybe what Anil Rama is saying is sometimes you get someone with a 5-liter engine and they're still not happy with their sleep. So we should err on the side of giving them the 2.5-liter engine because it looks better.
I think there's a lot of confusion there in that. I think there's some, you know, it may be true that someone needs 10 millimeters where other person needs 5, or someone needs 20 where they need 10, you know what I mean? And getting 10 is not going to get them 100% relief, but there's no question that 10 is going to be better than 5.
Like if you're Vegas, you bet on
more is going to be more.
You bet on the bigger airway giving 100%. You the better sleep result.
I think that where physicians like that struggle in that thought process is the reliance on evidence, like, there's no real paper that says this many millimeters is this or that. So it's like, because they didn't find any scientific study that's giving them exactly what they're looking for, the safe opinion is, well, it doesn't really make a difference what you do. But I think that's the wrong opinion.
Yeah. So as a physician, how do you make sense of deviating from the established? It's not that you're contradicting the literature. It's just that the literature doesn't exist.
It exists. I think they just haven't found it. So I think that physicians really need to think about they need to think about what they're doing. I think a problem is that you go through dental school, you go through medical school, you go through surgery training, and there's so much to learn. You know, it's like learning a new language. Before you learn a new language, you got to learn their alphabet, and then some words, and then how to put those words together, and then how to put sentences together, and how to put paragraphs together, and then how to tell a story, right? There's so much development that goes into that. Learning dentistry, medicine, subspecialty, surgery. It's like a language in that respect, where it's so much time, effort, sacrifice just to learn the language before you can tell the story, where people get stuck in this immense amount of process and information and tradition, where a lot of times they're just following recipes rather than thinking about what's happening. And I think people have a hard time with that. I think that the best thing a physician can do is really think about what they're doing. I constantly, every case I do, I rethink. What am I doing? Why am I doing it? What can be better? I think that people need to do that. Mm-hmm. And the same aspect about, why is this patient saying this? Why are they feeling these things? Why are they reacting this certain way? I think that the most responsible thing to do is really have this real thought process where it's not a 9-to-5 job where you come and operate and do what the book told you to do. I think that it's a constant journey to figure out what's happening. Yeah. And I think once people do that, the evidence is there. There's evidence for sure where the larger airway is better, that MMA is the best treatment for sleep apnea. It's not even controversial. It's just that people stop with what they know and don't go further, in my opinion.
I'm going to tie this in a second, but would you consider yourself someone who is to any degree airway challenged?
Yeah, a little bit, for sure.
And do you think your experience as an airway challenged, as a somewhat airway challenged patient, does that feed into the way that you practice in sort of giving you an intuitive sense of how this all connects and how jaw surgery ties in holistically? And is maybe jaw surgeons who operate toward occlusion and who are sort of in denial of the airway aspect of jaw surgery, are they lacking that sort of intuition of what it feels like to have small jaws?
Yeah, I think there's a possibility. I think there's a component of that in the sense that it's empathy. If you think about what a physician should have, empathy as a large characteristic to be a good doctor. You have to feel what the people are feeling to really want to help, right? And try to help. And I think the more you feel, the more empathy you have, I think that makes a huge impact on your responsibility and determination to getting that person better. And I think in a way, really feeling yourself that, when I'm congested and I can't breathe through my nose, I'm miserable.
Yeah.
And if I put on 10 pounds, I tell the difference with my airway. And I'm cognizant of it for sure. So I think that there may be a component from feeling it yourself, because feeling it yourself allows you to be more empathetic in a way.
Yeah.
Even just involuntarily.
No doubt. I mean, I'm obviously not a practicing doctor or dentist, but that's certainly my background in this space is all I ever did was come from a place of empathy. And I am an airway patient. And I could always just sort of feel the suffering that other people felt.
Right.
And I went through this process of feeling kinks in my own throat and in my own nose and just imagining what it would feel like to have another centimeter or et cetera, et cetera. I can imagine that.
Yeah.
And so it makes sense to me that if you do this, it would feel like this and therefore be therapeutic and solve this neck tension problem that I have or this snoring problem that I have.
Yeah.
And as someone who never spent a day in dental or medical school, that intuition and that empathy alone has gotten me to the point where I've been able to reach lots of people purely on empathy. Yeah. So I do think that's an important component.
I'll personally vouch to that character for you.
Appreciate it.
Because I saw you on Monday in our first case, never being in an operating room, never seeing blood or bone, and overcoming all that with excitement because you were excited for that patient, seeing those movements he had. So I witnessed that.
Totally.
So I'll vouch for that.
Yes, exactly. When I first walked in, you coached me on how, if I start fainting especially from dropping the maxilla, you said just, back up to the wall, sit down, take a deep breath. But instead, what happened was when you started doing all that, I was amazed and intrigued. And and I said this to you off camera, I said, instead of seeing destruction and hurt to the patient, I was seeing creation.
Right.
And relief.
Right.
I could feel the relief in that patient's tongue right away.
Right.
And so I think, honestly, that helped with dealing with the gorier side of it.
Right.
So that was very interesting for me to experience that. Yeah. Now, sometimes in the JawHacks community, people wonder, like the same, let's say 10 names that get handed around.
Yeah.
Are they Like, are they really the only ones doing this, or are these just the ones that somehow get mentioned on Reddit or on my channel at some point?
They're probably most of the group that do it consistently.
Incredible.
Yeah.
So
there may be, I look at these names too, and there may be, they're not, it's not 100% inclusive. Yeah. There are people that I know do it that are not on these lists, but I think they're few. I mean, the thing is that we talked about this, to be an oral surgeon is a very, the people that do jaw surgery, orthognathic surgery, they're for the most part oral and maxillofacial surgeons. And oral maxillofacial surgeons, some of them have medical degrees and dental degrees like I do, but almost all of them have dental degrees first, right? So they went to dental school first.
Yeah.
For the most part, there are exceptions to this. So, of all the dental schools in the world, 1 to 2% of the graduating people from those dental schools go into oral maxillofacial surgery. So there's the
cream of the crop.
Yeah, they're usually talented, hardworking people. That small subset of people. So it's a limited amount of people that even go into the specialty to begin with. And then the specialty is it's an amazing specialty with amazing people. I love oral surgeons. They're usually great people. And there's a really wide variety of things that they treat. Most of them, 95% or more, once they graduate, even though they train doing major cases, go into the communities and do wisdom teeth, dental implants, bone grafting, things of that nature.
Not orthognathics. And then of the 5% or less of that already small group of providers, you have some that go into head and neck cancer, some that go into cosmetic facial surgery, some that go into salivary gland stuff or some kind of rhinoplasty, or a pathology or even a trauma route, right? So you have a lot of variation, even in that very small, and then a very, very small of those 5%, maybe 1% or less that end up wanting to do orthognathics. And there are people that do orthognathics 5 to 10 times a year. And in that sliver of a sliver of a sliver.
Correct. And then there's a very, very handful or more people that say that they're primarily orthognathic surgeons.
Yeah.
It's a very, very small community of providers. Now, if you're a patient, I would advocate to go with someone that has experience with this, because it's a technically difficult operation that I think requires experience to do well. So you're going to, favor an orthognathic surgeon to do this. But the reality is that the access is limited. There's not many providers.
Wow.
Yeah.
What an incredible thing to think that, because I think people have a hard time finding the boundaries of trying to understand the jaw surgery world before they commit to such a major process.
Right.
And there's this, it's nice to know where the boundaries are, because you feel like your knowledge is getting somewhere close to complete.
Right.
And that gives you confidence and reassurance before actually pulling the trigger and doing it.
Yep.
And insecurity I've had as an educator and as a researcher and journalist in this space is, I don't know what I don't know.
Right.
I don't know maybe there's a savant surgeon out there whose name just hasn't appeared yet on the internet, and they're really the best one who gets you the best outcome. But what I've learned from you this week is that's probably not the case. The names that I'm dealing with on my channel might actually be the only names.
Yeah, they're a high percentage of the only names, because, they're doing a high enough number that their name is being bounced around.
Right.
And a high enough number, I'm talking about 50 plus cases a year. 50? Yeah, 50.
So on that note, this is a thought that I had, which is
even 30. Even 30 plus
is a lot.
Yeah. That's technically someone that does a lot of orthognathic surgery.
For traditional.
Yeah.
So there's this idea that because you're doing quadruple that, more than that, you did 200 cases this year.
Right.
That somehow that means that your surgeries are lower quality because you're doing volume.
Right.
But the thought that I had is that actually, because your way of doing surgery allows you to do more surgeries,
Correct.
that just means you're getting more experience and refining the process.
All I know is my own experience, and comparing myself now compared to 5 years ago, it's a completely different experience.
Because of the volume.
Because of the volume. Every year I'm better.
Right.
Every single year I'm better because of the experience.
But it's this counterintuitive thing where actually volume means quality.
Yeah.
Because of the increased experience.
100%.
To the point about technique affecting planning, because with custom, for example, you're able to get more aggressive advancements. So that allows you to plan for more aggressive advancements. It's not just a matter of beauty. It's a matter of practicality and achievability. You taught me something earlier today. Actually, you did this in the surgery. Because it was such a dramatic mandibular advancement, the biggest problem with bold mandibular advancements is the tension that's created.
Right.
And you were telling me about how you had to release some soft tissue in order to make that stable and reduce the risk of relapse.
Right.
Can you talk about what you did in that patient to make the site a little bit more passive, to hold the mandible in that new position?
Yeah, definitely. So the mandible, the lower jaw is the mandible. It's encased in different layers of soft tissue. The first layer that's on the bone is called periosteum, and it's a tight layer of tissue. It's pretty tight. And it's like a glove, right, on a hand.
Is it bone or is it?
No, it's a connective tissue.
Okay.
Yeah. And it lines the jaw and it's tense, right? Outside of that, there's muscle, there's fat, there's ligaments. And what it creates is an envelope of tissue. Now, when you make this cut here and you move this apart and you bring that jaw forward, even though you're separate here, as you bring this forward, the envelope is still connecting the entire jaw.
It's like a rubber band of soft tissue that's trying to close that BSSO gap that you created that's being held open by the plate.
Even though the bone is separate at the time, the two components are not entirely separate because the envelope is still hugging it all. And what that does is for larger movements, that tension will bring this segment forward outside the TMJ. It'll distract it down. And it'll be tense when you're feeling it. So a surgeon can easily think that he's in the position he planned, when in reality, he's just opening the jaw forward.
Dislocating
the condyle forward because that envelope is pulling it down. So that's a huge factor or benefit of custom plates is the reference of the plates, like you saw today, gives me that information if I actually have the right position or not.
Yeah, this advancement is not coming from forward dislocation of the condyle in that whole segment.
Right.
It's actually coming from the gap being appropriately sized.
Correct. And the only way to really know that is to have that reference from a custom plate. Yeah. Otherwise, it's impossible. There's no way to know it because the tissue can be so tight, especially for a large movement, that you feel like you're up against the right place, where in reality you're just up against an envelope that's stretched.
Yeah.
So I think that in those situations, the custom plate tells me that I'm not there yet and I have to do some more work. And that more work, usually there's very strong ligament attachments and tendon attachments at the gonial angle here, for the masseter muscle, and the pterygoid muscle, and they're really tense fibrous tissues. So often have to go back and release the attachment of those.
What do you mean by release the attachment of those?
Strip it off the bone.
You just take it, peel it right off.
Yeah,
which people will probably like, wait, you can't do that. But
yeah, absolutely.
You can do that.
I mean, you have to expose the bone anyways. When you're exposing the bone, you're moving the periosteal layer off the bone. This is just going to areas where there are tighter attachments and doing the same. And it's the same thing on the medial side. There's the stylohyoid ligament, the stylomandibular ligament. They're coming from these areas and they're very tense, and sometimes I'll have to release those. But before I started to use custom, I didn't really understand that because I couldn't understand that. Instead, we wondered why there was this immediate relapse in some cases, and now I know it's from the envelope that was fighting that. But now I have that information to prepare the jaws ready for that final position because of the information that we have. And it allows me to make larger movements predictably, safely, and with stability.
And if you remove the soft tissue from the bone, it'll just, so you relieve the tension and now you've plated the lower jaw forward. And so then how does that heal?
Yeah, so now the soft tissue drape will reattach to the new position and form new ligament tendon attachments.
And it'll heal in
and
that.
It'll heal in that position, but it has to be passive when you're fixating it.
It's not going to heal with tension.
With tension, it's going to start pulling everything back or even putting you right away in the wrong position.
Yeah. Now, tell me about surgery first versus surgery after.
Yeah.
You're okay with surgery first.
Yeah, I like it.
Who is a surgery after case? Who is a surgery first case? And what are the risks of surgery first?
Yeah.
On my channel, I've talked about the risk of doing surgery first as if something goes wrong, the surgeon blames it on the orthodontist. And so better to do orthodontics first to make sure that the bite is perfect. And that way it sort of idiot proofs the surgery and allows the surgeon to just do the advancements,
right,
knowing that the bite is going to be good. But how do you make sense of surgery first? Yeah,
it's a great question. In reality, every case, whether it's surgery first or braces first, there's always braces or Invisalign after. There's always orthodontia after to control the bite.
And why is that? You explained because when you sever the jaws and this inflammation process happens, and that can cause the teeth to free float a little bit.
Yeah, move. The teeth will shift. Things will shift because the teeth are in the bone that's healing, and that healing bone is fluid.
It's inflamed. It's etc.
Yeah, we know it. We call it a rapid. What is it called? It's rapid movement of the teeth. Some people use that in favor of orthodontics, like SFOT does that, for example.
Right. You traumatize the area and then you get
and
faster.
The teeth will move faster.
Exactly.
So it's that same phenomenon that we know, and it makes sense because the bone is going through this inflammatory phase.
Yeah.
And the teeth will start moving, and a millimeter movement is a highway for teeth. It can change the bite tremendously. So you're always going to control the bite afterwards. There's always going to be some finishing to do. Thankfully, we can do a lot of them with Invisalign now. So that means that if you can avoid 6 months to a year of braces, because no matter what, we're going to have to fix the bite, have some finishing to do afterwards. There's clear benefit of going to surgery first if you can. Now, there are times where I can't do that is when the teeth are so crowded or compensated where they're angled inappropriately, where I can't put them in a good position because of the angles of the teeth.
What kind of angles are we talking about?
Like that the front teeth are in a overbite. The front teeth are flared horizontally forward.
It's a compensatory type of position.
And if I don't do braces first to undo that, I have no room to go forward on the mandible.
And is that what we call, so this is compensation and decompensation.
Right.
People have heard of pre-surgical decompensation.
Right. Correct.
That specifically refers to uprighting the teeth from a tipped position that's sort of maybe the result of them coping for having small skeleton, and so they push the teeth out as a result over a lifetime.
Yep. So some of that has to be undone. And there are cases where those compensations are not that great, and we can get the jaws in a good place and then finish the bite afterwards. That's a great case for surgery first.
Yeah.
Let's take a break.
All right. So we're back after a little break. You had to see some patients. We were looking at this week someone who had really good jaw structure. Like this person was from South America, and they had an exceptionally strong jawline. And I asked you about the neck posture because this person also had ramrod straight neck posture.
Yep.
Neck posture is very controversial.
Yeah.
In healthcare, and even in all YouTube health communities, no one knows their ass from their elbow when it comes to posture in general, but especially neck posture.
Yep.
Because the ramrod straight neck posture is poo-pooed normally. Mm-hmm. What is your opinion on the relationship between jaw structure and neck posture? And is that ramrod straight neck posture actually healthy when it has the jaws that sort of support it, I guess you would say?
Yeah. I mean, the straighter the head sits, the better. And if you look at healthy children, they stand very straight and tall. And if you look at indigenous groups that have strong jaws and airways, they stand straight and tall. And you look at people that have amazing posture, and they usually correlate, like you just said, with strong jaw lines and subsequent good airways. And then we have surgery patients, and again, go through the before and afters. And when the jaw gets stronger and the airway gets better, the posture is always improving. So it's like there's clear evidence that there is a correlation. And I think that people that look into it accept it.
Yeah.
As truth.
And if the jaws are big enough that you reach like an asymptote as to how straight the neck can get,
right,
and like it actually gets like up,
yeah,
like
straight.
Boom, no curvature,
right,
none of this.
Yeah.
It's just like boom,
yeah,
and then a massive projection of the jaws.
Right. Yeah, and I think that's very healthy.
Yeah. And
yeah.
But you never actually see like surgical cases getting that ramrod straight. And is that sort of speaking to the limits, or maybe you do? Is that speaking to the limits as to what surgery can actually achieve in terms of replicating?
I think it'll always improve, but I think once there's arthritic changes in joints and structures, there is a limit to how perfect it can be.
Yeah, and does that get into like the vertebrae at the cervical spine and?
Yeah, I mean you can't undo all doing.
No, especially after a couple decades.
Right, but that's okay because it's all about doing better and improving and getting as healthy as you can be, and I think that's at the moment that's the goal. Yeah,
that's interesting. A quick question about the pre-printed plates.
Yep.
You could imagine a nightmare story.
Mm-hmm.
This is a criticism of the pre-printed plates approach.
Yeah.
A nightmare situation where you trust the plan you created.
Right.
You arrive for surgery. Here are the plates. You put them in just trusting that they came from the printer as you designed them. But let's say the printer screwed up and they're off 1 millimeter on one side, and now you've got a cant or something like that.
Yeah.
Is that a valid concern? Do the pre-printed plates ever come wrong from the manufacturer?
Yeah. No, I mean, it depends if it's being printed in a garage somewhere, bootleg without any checks and balances and approval process and FDA scrutiny and all that. But for the major companies like DePuy Synthes, who's owned by Johnson & Johnson or Stryker or KLS, the processes they had to go to ensure precision are significant and great. Yeah.
They double check the plates, basically.
Oh, yeah. There's a huge testing process before they can leave the factory and get out there. So in my experience, 6 years, average of 100 cases a year or more, double jaws I'm talking about, they've always fit exactly to plan.
Never had a bunk one?
Not once. Now, there is for comfort of mind, peace of mind for the public out there, there is verification in the operating room. As you saw, we can put a final splint to confirm that we got what we planned.
Right.
And that's what we do always. We confirm it. And if not, we can always use the splint and resort to traditional methods. There's always plates in the operating room where we can do it like everybody else does it. So that assurance is there, not only from the checks and balances from leaving the factory itself, but there's checks and balances in the operating room.
So two things would have to go wrong. More than one thing would have to go wrong in order for that to get missed and show in the final patient outcome.
Yeah. A company would have to have some kind of sabotager that got it out in the mail without going through their official processes, which is obviously
an absurdity.
And then the surgeon has to not know how to execute a surgery and check it.
Yeah.
Which is not going to happen.
Okay, while we're on that subject, I was telling you the other day about that case I saw about that kid who went abroad and he came home with a really bad cant, and on the x-ray showed that one side of the maxilla was way lower than the other. It was just like this egregious surgical mistake that resulted in a cant for this guy. And I remember you had an explanation for how that happened because non-pre-printed plates were used. What causes that sort of botch?
So without custom plates, it's impossible to get accuracy in all dimensions. And what happens is when you're relying on wiring the mouth shut to give you that information, as you move things forward and stretch it and fight that bite to get in, and that's your marker, the lower jaw can move. So even if you're doing, let's say, the upper jaw, you're still relying on that position of the lower jaw in that traditional sense, because you're wiring the mouth shut. So you're moving something forward, you're rotating the lower jaw. And if you unknowingly can distract one side down, that condyle out of position, there's no way to know that because you're just bending a plate in that position, right? So to what degree you're distracting it, you should know, but you should know if it's obvious, but it's not 100% accurate or available to know that you have that exact position that you plan. So vertical positions can be different than what you planned with non-custom, and pitch and yaw can definitely be not what you planned based on how you're holding that condyle. Is it distracted or not? So it's not uncommon to have variations or imperfections in cant, pitch, vertical position with traditional jaw surgery. People see it all the time. Thankfully, clinically, it's not so significant in most well-executed surgeries. It's not perfect, but it's not clinically.
Like if you're skilled enough,
if you're skilled enough, you can avoid it, but you're not going to get it perfect. Even the most skilled guys using non-custom, you put it against a custom, well-executed, one's going to be way more accurate than the other.
Right. So if you were reverse engineering that specific botch, do you think that what happened there is the mandible was done first and there was maybe a condylar sort of setback?
Yeah, something was plated with the condyle out of position.
And then it was...
or there's that yes. And the reason for that in a lot of cases will be interferences. So if you have interferences, which you don't know are interferences, meaning the bone is being stopped.
Bone-on-bone contact.
Bone-on-bone contact.
Around the BSSO cut.
Around the cuts or the maxillary cut, right? In the instance of the cant, the maxillary cut. So that you're pressing it and there's interference. That interference can distract that condyle out.
Yeah, interference is a really important concept.
It's a really important concept.
Do all jaw surgeons talk in terms of interferences, or is that a custom thing?
I think that it becomes more philosophically relevant and understanding when you use custom, because you can see that sometimes you need to do a little more work to get you exactly where you plan. So that's where an interference has become an obvious important factor. Whereas with non-custom, I think that...
You don't even know the interference is there.
Correct.
You don't know what you don't know.
Exactly right. You don't know what you don't know.
Yeah.
Exactly. So I think like for me, the evolution of my career going from non-custom for so many years, doing it the traditional way and then going to custom is like how much I learned actually.
Yeah.
About stuff I wasn't aware of.
Interesting. Yeah. Because the definition of an interference in your way of doing surgery is something that prevents the plates from fitting.
Yep. Exactly to plan.
Exactly to plan.
Right.
So when you say we have a 2 millimeter interference here.
Yeah, I need to work on those interferences, relieve that space so it's not interfering with my position.
Right.
But I know that. And without the reference points from the plates that give me exactly to the millimeter that's happening, it's impossible to know that.
Right. Another contrarian view that you expressed to me this week during our time together was the way that TMJs are able to heal or function even from a place of apparent damage, where in some cases you might get, the conventional view would be to replace the joint.
Yeah.
But your position is more to set the stage for the joint to heal.
100%.
And then to let it do its thing and to avoid the replacement.
Yeah, 100%.
Can you speak to that?
And I can. I like talking about this because it's really interesting. And I think that it's something that as a specialty, or even in medicine, there was a poor grasp and understanding of it, and the attempts to make things better were going after the joint that had problems. When now we have tools to open up airways, fix the function, make the appropriate movements, and keep the joint neutral, like we talked about, we can actually get the health of the TMJ better. We're learning so much more. It's interesting because, you know, as a specialty, we accept some things. Like we have people that break their condyle. They have a fracture. Like if they fall off a horse, for example, and fall in their chin, both condyles can break at a high position.
Any chin first impact causes these little twiggy condyles to snap.
Break at the neck over there. And if it's high enough there near the condyle head, the accepted treatment for all oral surgeons is you can't really put a plate there because there's not enough bone stock. It's just the head of the condyle. And those condyles, the medial pterygoid pulls it in, the condyle goes medial, right? And then the jaw goes back because it loses distance. And what we do for treatment is get them in braces or arch bars and put elastics to hold that position forward so it doesn't
slide
collapse.
Up and back.
Right. As long as we hold them in that position and have them function, they'll heal.
What do you mean they'll heal?
They'll remodel a joint in the appropriate position.
Will the fossa change or will the condyle
the condyle probably, maybe the entire joint itself, but most likely the condyle. But what'll happen is it'll still look funny afterwards because you had this other part go medial. Now you have a new kind of joint developing, but the body will do that. So we know and accept that that's the treatment. That's the standard. Is we're not plating those high condylar fractures. We're letting them heal. But in essence, what's happening, the disc is now out of position. The condylar head anatomy is different, but we know it works, right?
It's an acceptable outcome.
Yeah, and it works. And the only thing that can happen, as long as it doesn't fuse and scar, and we avoid that by having them mobilize, is that if it doesn't gain all the dimension and it collapses a little bit, that the bite might be off. But then it can be, the joints are still healthy. There's no reason to replace them. It either means braces to fix the bite or orthognathic surgery to regain that advancement. Right. But the joints itself are fine. They're going to remodel and do well, even though they look funny. You know, so it's like we know this thing, and we know that we have tumors of the condyle or cancer, and we take it out completely and replace it with leg bone or rib. And those are funny bones without a disc position appropriate, and people do fine. Right. So like in the cancer reconstruction bucket, we know that the joint doesn't have to look perfect, that it, as long as it's functioning and hinging and it's a joint and you put something there, it'll work. We know that in the trauma effect. We know that in the total joint replacement. If you put a metal piece with a plastic in the right place, that looks funny on an x-ray too, in my opinion, that it's going to function. So you have trauma, you have pathology, reconstruction with different bones. And then we have kids. As a specialty, we see craniofacial kids with hemifacial microsomia, or these golden hour syndromes.
What's that look like? And
some of these don't develop appropriate condyles or TMJs. Right?
It's just so like missing, kind of?
Different variations. They could be completely missing, or they can be deformed or smaller. But even in those cases, they might have a cant because one side's shorter than the other. But those joints, as funny or missing as they are, they're going to open and close, right? So it's like we know these things about the joint. The joint has the anatomy of the face is privileged in its blood supply and ability to heal. It's different than some of our extremities and long bones. It has a very special privilege that it can heal better than other parts of the body. The mouth is the same. The mouth can take a lot and heal. The tongue can be cut off and heal, right? So we have to think about that and this is what we talked about before. People don't step out and really think about what's happening, and we go by the recipe. So the recipe is like, oh, the joint hurts. Let's the disc. Then you take an X-ray. They have arthritis or a disc that's malpositioned, and those become targets to treatment and justification from the doctor and the patient to say your disc is out of place. You have noise. You're bone on bone, whatever it is. It's rationalized to go, you have to treat the joint. When if you step out and say, no, you don't. The point of the joint is to open and close in a healthy way, right? And those joints are if you give them a favorable environment, whether there is a joint, it's a plastic joint, it's a metal joint, it's a rib, it's a fibula, it's a deformed joint, it's a traumatic joint, it's an arthritic joint, no matter what, as long as you give it a good environment and function, it's going to succeed. So once people realize that, are we really needing to go after the joints and replace them and take away real bone and replace it with something else? I don't think so. I think that we should really be looking at root cause. And most of these people, like we talked about, it's an epidemic. It should be something of exclusion if someone has appropriate jaw size or not. Because if you look at the current state of man, our jaws are too small, right? So the airways are a problem for so many people. And if the airways are a problem and the mechanics of the bite are a problem, they're putting a lot of stress on those joints. And it's the reason that a lot of people have TMJ symptoms and pain. And what I've been finding in my practice, especially in the last couple of years, as I take on more airway cases and identify more airway cases, is that whether their chief complaint was TMJ in the beginning or it was sleep apnea, once we fix the bite and open up the airways and get them working with a myofunctional therapist to function better, sleep better, those TMJ symptoms always get better every single time. And now this person avoided a more invasive procedure like a joint replacement. So in essence, what I'm saying is like not popular just because the popular way of teaching is to go after these joints. But
to replace them
or
otherwise treat
or do
them.
some invasive procedures on them. But this is not only something that works, it's more conservative, right? It's the least aggressive path.
Can you speak a little bit as to how airway disorders cause TMJ symptoms? Because you've alluded to that point several times in the interview, but it's very counterintuitive or very, it's not straightforward.
Yeah. So what happens is to keep the airway, an airway that's restricted, meaning the space behind the tongue is small and airflow becomes a problem, especially when someone lays down. Gravity gets worse. A lot of people, even we talked about this before, if you sleep on your back, you do worse than on your side, right?
Yes.
Because the tongue can fall back and restrict that airway. And then you have a bottleneck of airflow. So people are more prone to having breathing issues at night when they're sleeping for those reasons. It's an anatomical position. It's a gravity thing, but also what happens is when someone starts to sleep and relax and they get to deeper stages of sleep, so soft tissues relax and that space will narrow more, right? And it'll close more. So like that's what the DICE procedure is.
Right.
Drug-induced sleep endoscopy is really just to relax them enough to see if they're obstructing or where they're obstructing. Because when the muscles relax, a narrow passage will obstruct.
Yeah, it's a diagnostic procedure used to try to identify the airway kink that's causing someone's sleep disorder.
So all this stuff is pretty common sense, right? So like we said, breathing and air, oxygen is everything. Without it, we don't have life. So the body will not allow someone to completely suffocate. So what happens is when people sleep that have a small airway, the body has to compensate to open up that airway. So while someone's asleep, they clench their teeth, they posture around, they move around, they're putting a lot of pressure on their jaws for many hours every day. And on top of that, most of these people have poor mechanics. Their bites are not good. They have crowding, they're retrognathic, they have underbites, overbites. So you have bad mechanics and 6 to 8 hours of functioning on that joint every day. To me, it makes all the sense of the world that that's contributing to TMJ destruction.
Right.
and aging. I would call it aging, right? Because at the end of the day, nothing stays pristine in our bodies. Everything has an aging process.
Yeah.
And arthritis is really just an aging process of the joints. The TMJ problems are just an aging process of joints. And what's happening is that aging of that joint is accelerated in these conditions. So undoing that, giving appropriate airway, fixing the bite mechanics gives the environment of that joint a much better position to slow down that aging process and function better.
Right. And even though people say that jaw surgery can cause TMJ disorders where they didn't previously exist,
right,
according to your ultimate root cause understanding of TMJ disorders, which is to say that they're symptoms of airway disorders,
right,
then jaw surgery, at least the way that you do it with custom plates where the TMJs can be precisely positioned,
right,
it's actually not a risk factor for TMJ disorders.
Exactly.
It's the cure.
Right, exactly. It's kind of two different things. One is that getting a better position helps the TMJ, but the other part of that is that before custom technology, the surgery itself, like we talked about, can torque the condyle and make the TMJs worse. But now that we have this technology, that's not a factor anymore. So we can only work towards making things better and not worse. But that's only because of the technology that's available now. But historically, in the traditional sense, jaw surgery risked the TMJs.
Yeah.
But that's traditional, non-custom.
And how do you plan for TMJ health in your pre-surgical planning? Like, what's the workflow there?
Yeah, so the workflow is whenever we're planning for surgery, we're always positioning the TMJ in an appropriate position. And we do that. You saw how we do it. I'm there physically guiding them into appropriate bites, and then we make sure on the cone beam CT that the joint looks like it's in a neutral position. That way we're planning off a good position. Then when I'm planning, I make sure that I don't want to rotate that condyle in a compromised place. I want to keep it as neutral as possible, so it's not putting undue forces with the ligaments or muscles.
So in a sense, would you say that the whole surgical plan is kind of built around condyle position?
Yeah.
Like that's your starting point?
That's your starting point.
And you just go off from there?
Yeah, and that's I'm in the room every time for those, and that's because that's a key component of the planning process, is to make sure that the TMJs are looked at. So
then the only uncertainty when it comes to TMJ health becomes like the orthodontic component? Like the orthodontist you would need to finish the bite in a healthy way. Right. Yeah. And that's a collaboration with the orthodontist. It's very important that the surgeon and orthodontist are working together and understanding and making sure that the bite is finishing in a good place. Because otherwise you can do an amazing operation, but the teeth are not controlled well and the bite is not healthy, and that continues to age the joints. Right. Does it frustrate you sometimes that the orthodontic part isn't totally under your control? Yeah. I mean, it's definitely a factor. For sure. It's why we have preferences of which orthodontists we're comfortable with and want to work with, because, especially as I see more and more patients from everywhere around the world, right. I interact with a larger variety of orthodontists, and it's something that definitely takes a learning process to try to get everybody on the same page and understand that, the workflow is appropriate and the skill level is appropriate, and the fit is appropriate. Yeah. To work together. Yeah. I could imagine a patient coming back with the TMJ concern and it being the orthodontist's fault essentially, and the patient not understanding that and somehow blaming you. I mean, there's so much out of control. Yeah. But as a surgeon, the unfortunate truth about being a surgeon is no matter what factor it is outside the control of the surgeon or, different providers, the surgeon's always responsible. Why is that? Because you're at the top of the food chain? You're at the top of the food chain. It's, it's the same not only in that aspect of the ortho finishing, but it's even in the operating room with anesthesia. I mean, you may not even touch a patient in the anesthesia, whether it was
a fault or not fault, but the anesthesia can do something catastrophic, and the surgeon is always the one that's going to be responsible. So,
oh, really?
Yeah, it's something. The surgeon is the provider. He's the responsible person.
Right.
So whether it's fair or unfair, it's part of being a surgeon. Is that you're the captain of the ship.
Yeah. So with power comes responsibility.
Right.
One thing I noticed this week was that you had a lot of teenage patients come in.
Yeah.
Actually, some of the favorite patients that we saw this week were young teenage patients, some of them with sort of like genetic conditions, or almost you could say birth defects, which were, these were not people like me and a lot of people in my audience who are just biohacking. And these were kids with serious jaw deformities that looked distinctly sort of deformed, and that really needed this surgery. Like they needed this surgery. But they were under the age of, let's say, 22, because I had heard a prominent surgeon say in a different podcast that he will not operate on anyone younger than 22 generally, because it's not until that age that you stop growing. And that operating on someone younger is like, it's like a moving target. You could move the jaws and then they change because of growth, and now it's not where you put it, or something like that. Why do you treat teenagers, and like what's the youngest patient you'll treat? And then also I want to talk to you about treating elderly patients, because we've also seen some older patients this week that had a great one in particular that had a really nice result that we saw. Could you speak about age?
This is great. I love that question. And it's something that, and I like to, when I give lectures to residents, I like to have them have some perspective that a lot of the books we read on surgery and protocols were written at a time that didn't have the tools that we have today, right? So a lot of these things that we still look at today as the recipe for how to do surgery, what the protocols are, they were based on information that's not entirely relevant to today's information. It was pre-custom plates. Some of the information is even pre-plates, when we used to use stainless steel wires to fixate jaws. So now that we have different technologies, virtual surgical planning, custom plates, and they didn't have it before, I encourage residents to take that into account, in that what you're reading had limitations on what they can do, and it's not as always relevant to what we have now. So in the traditional sense, the surgery, like we talked about, was a long operation, a really difficult recovery, and unpredictable and unstable. So when there's so much, it was a surgery that we tried to encourage people not to do unless they really, really had to do it. So anything that added to any unpredictableness became a let's not do it.
It was just too much.
It's already unpredictable, unstable, difficult recovery, all these things. So now you add someone that's growing potentially, or someone that's older potentially, and your cutoff for making rules is different, right? Where it's not now, it's like the surgery is predictable, safe, the recovery is better. So it becomes a risk benefit thing, like it always was. Right. So a kid that has an obvious deformity at 14, 15, and sleep apnea is a problem, they're not really tolerating a CPAP or don't want to wear a CPAP, they're suffering. They're suffering not only from the social aspects of having whatever position that they're in that's unfavorable, but also from the health aspects that they're not breathing well, they're not sleeping well, they're not speaking well. And it's such an important time for these people. They're developing. Where is it more important to sleep and get oxygen than in development? Some of these things are irreversible in terms of time period.
Totally.
So if you can get a kid out of trouble and make them healthier faster in a predictable, stable operation, it's a no-brainer. But we have that now, where traditionally we didn't have that. The problem is people still operate off the traditional textbooks and philosophies, not really realizing that was a different time.
Right. I'm trying to think of an analogy. Maybe it's like we talked a lot this week about the analogy between surgical technologies and like military technologies. Maybe it's like people are still reading the military textbooks about like pre-aircraft,
right.
and they're like, oh, we have to send this many people on the ground, otherwise the invasion won't work.
Yeah.
When in reality, the technology exists where maybe you only need to put 50,000 on the ground and the rest can be by air, instead of sending 1 million by ground, storming
Right.
the beach or something, right?
Right.
So people are still using old philosophies, even though new tools are available. They're still reading old textbooks where it says you can't treat anyone over
Correct.
50 with jaw surgery.
Right.
You can't treat a 15-year-old.
Correct.
Even though the technologies totally allow for
Completely
it.
different now.
Right. So specifically with older patients.
Yeah, same philosophy. I mean, it was in the past, it's like, you know, are you going to put an older person? Older people have more comorbidities, especially if they have these deformities for a long period of time, right? They've been having sleep apnea for a long time, which affects their heart health, their lung health. So their ability to safely go under things, it's not like a teenager, right? So
Yeah, right.
there was a hard stop, the risk benefit thing. Again, you know, are you going to put someone and risk this when it's such a difficult thing? But now that it's more predictable, more safe, it's not that there's no risk, there's still risk, but the risk benefit ratio, everything is a bet in life.
Right.
Right. But it's a better bet.
Right.
And if you have someone that's really suffering, and, you know, if you don't do it for these people, it's definite spiral down.
Yeah.
For a lot of these patients, like they're not tolerating CPAP well, or even on CPAP, they're not getting benefit and they're really suffering. And yes, there's risks to doing surgery for these, and it's a discussion we have to have, but there's a definite risk of not doing surgery.
Yeah.
Right. So it becomes, the technology allows us to do it safely, predictably, and makes the risk benefit seesaw way in favor of benefit for patients, where in the past that pendulum was the other way.
Yeah, right. And specifically with older patients, the concern is obviously the recovery.
Right.
Like you wouldn't want to put, I don't know, a 70-year-old through a traditional jaw surgery recovery, but
Right.
maybe you could put them through a custom jaw surgery
Correct.
recovery.
Yeah.
Have you ever treated someone like 70 plus?
Yeah. 60s, late 60s.
Yeah, would you?
Many in the 60s. Depends on the health
Yeah.
of the person. You know, people age very differently.
For sure.
And there
No doubt
are
about
70-year-olds that are healthier than a lot of 50-year-old patients I see, and vice versa.
No doubt.
Yeah.
And on that note, what was that thing you were telling me about? Part of the reason that younger patients aren't treated is because of a misunderstanding about how bone grows around plates. You were saying that bone is not like wood. People
Right.
imagine it like putting metal on wood. Wood is like a dead substance, and
Right.
that. What was that you were telling me? Do you remember?
Yeah, I do. So the question is, so we talked about what is the youngest I've ever done jaw surgery. And
Yes.
It was around 7 or 8 years old.
Incredible, right?
And this was someone that had a Naegger syndrome, which is a craniofacial syndrome, and really severe small jaw that had already had some distraction in neonate when he was very, very young, and his jaw had fused, and now he's really far back. And at 7 or 8, his sleep apnea was so bad that the only real option was to do a tracheostomy, which I think for a kid is obviously it's a big deal.
Yeah.
Right. A very big deal. So the risk benefit in this case, knowing that we can do the surgery, I decided to do jaw surgery to bring that jaw forward. And the kid did tremendous.
Yeah.
He did tremendous, and it was, safe and successful, and he avoided a trach as he started to grow faster and really thrive, and it was an amazing thing for him.
So the surgery supported a healthier kind of growth.
Yes, exactly, because he's breathing better and sleeping better. He's getting oxygen. So
because why assume that growth in a growing patient after surgery is going to be a negative thing?
Right. Yeah. I mean, if you're breathing better, sleeping better, and you're still growing, it could be a tremendous biohack.
That's just an assumption, right?
Right.
That people make?
Yeah.
That it's going to be negative? It could be positive.
Yeah, definitely could be positive. definitely should be positive.
Right.
Yeah. So I think, it all comes, all medicine, all surgery, and all decisions, investing, decision of who to marry, what relationship to be in, who to partner business with, everything has risks and rewards to it. And things need to be evaluated for, is it a better bet to do it versus not do it? And, thankfully things in surgery are evolving, whereas there's becoming a greater percentage of people that can benefit from these things.
Pendulum is swinging.
The pendulum is swinging. Yeah.
So on that note, I want to talk about my case for a second.
Yeah.
People have been tracking my face essentially in my airway since 2017.
Yeah.
So people, I think my face is a good reference point for people to understand who really qualifies for a jaw surgery and what can jaw surgery do for someone who doesn't seem like they need it.
Yeah.
Although I was telling you this week that 1 to 2 times a week, I do wake up gasping for air, usually out of a bad dream.
Yeah.
Like the other night at the hotel, I was having this dream that I was stuck in an elevator with some weird person. I was like, yo, why are you acting so weird? And then they took out a razor blade and they started slicing my legs with it, and I could feel the slices. And then I was like, oh, fuck, these guy's murdering me. Right. And then I woke up and I was like, and I had been on my back and not breathing well, and I could feel a ton of neck tension, facial tension, all of my pre-migraine symptoms.
Yeah.
I went to bed feeling great. I mean, we had an awesome day together. I went to bed feeling like $1 million, yet I woke up with this pre-migraine.
Yeah.
Presumably because I was having
airway issues.
An airway episode.
Yeah.
So what do you think about my candidacy for an MMA surgery, and what types of movements might we be looking at for me if I were to ever do it?
Yeah. So I think you're definitely a candidate for it. Those are real symptoms and signs. And I think that in my practice, I would definitely send you for an in-lab sleep study to get some objective evidence on what's happening. Based on what you're describing, the chances that you have some respiratory disturbance, whether it's the sleep apnea itself or airway resistance, is high. I think it's probably true. And that makes you a candidate for jaw surgery. Now, the movements and the whole thing about customization in medicine is everybody needs different movements, right? So you probably need less than some patients. It may not be a 20 millimeter or 10 millimeter. It might be a 5 to 7 millimeter, but that can make a huge impact on your health and well-being. Yeah. I think, and we touched on this earlier in the week, is that if you accept that over the last 500 years, jaws are smaller, right? We're used to seeing each other in smaller jaws. So our perception of what's normal is handicapped, right? And if you zoom out and put us against thousands of years of people, like
the paleo face.
Yeah, the paleo face. I like that.
Now I'm officially the first person to ever use that term on the internet.
It is you. You coined it for sure, and I like it. The paleo face, but it's true. If you put, our average face, and put it against the average faces of thousands and thousands of different years of people, it's smaller and it's different. So what we're used to seeing is handicapped as appropriate. So you have a good face, in the normalized sense, where that most people will look at you and say, you're not a candidate for
I have a
surgery.
relatively good face.
A relatively good
compared
face.
to 21st century men in America.
Exactly. But in essence, everybody is a candidate. And I think that it will come to a time soon when this becomes safer, more accessible, continues to get predictable and stable, that it becomes a treatment of, a question of exclusion rather than inclusion. Like people screen for heart birth defects, we should be screening for, are you going to have an airway problem?
Yeah.
Right? Because I think the reality is that most people are candidates for a better airway. Yeah. And especially if you consider it as a biohacking tool, which I've considered to be, to give you, better breathing, better sleep as a condition for better living, then even a good airway can be better.
Right. This week, we've talked a little bit about the bigger picture of spirituality and our metaphysical understanding of the world. And we talked about how I see the world in terms of a good evil duality.
Yeah.
And that you're sympathetic to that view.
Yep.
Would you go as far as to say that you sort of agree that there is a good and evil forces out there that are acting on humans? And
I believe that.
How do you think jaw surgery and airway health and the jaw size epidemic, et cetera, sort of factors in to well-being and sort of the struggle to be good and to not be, drawn toward negativity, evil, and being sort of sucked into the vortex?
Yeah. It's an interesting philosophical question, really. I think it's huge, actually. And the way I think about it is, we all have the ability to make, we make decisions, good decisions or bad decisions. And the evil energies will make us make bad decisions. For example, you can think of it that way. Versus positive energies give us good decisions. A very rough, idea of this. But what happens to someone when they're weak and handicapped? And do they let more entry for negativity and negative influences and bad decisions? And it's similar to alcohol, right? Alcohol weakens somebody's mind in the current state, right? Yeah, also in the chronic state, but in the current state, inhibition is down, frontal lobe is not accurate, visual cortex is not 100%. We know that you can't drive as well under the influence as you can. You're not functioning at 100%. So people do stupid things under alcohol, right? Because it weakens them and allows bad forces to happen. So
totally.
in that same essence, bad sleep, bad oxygenation can handicap people and decrease the threshold for worse outcomes in all aspects of life.
Yeah. The etymology of the word alcohol is actually the Arabic word al-ghul, which means the monster.
Yeah.
Which sort of feeds into the point that alcohol and inhibition can turn you into a monster.
Yeah.
It can subject you into monstrous forces.
Yeah, and we've seen this. We know this.
Right. So, again, another sort of counterintuitive thing is a lot of people see jaw surgery as a kind of vanity procedure,
right?
Which would be sort of anti-good because now I'm focused on looking better, and that's vain.
Right.
But actually, it can be seen as something that can enable you to be a better person,
right,
by giving you a stronger mind and therefore making you less susceptible to the so-called voices,
right,
that can pull you, the worst angels of our nature.
Right.
Abe Lincoln talked about responding to the better angels of our nature, the good birdie on your shoulder from the Looney Tune cartoons that we were talking about.
Yep.
So
I think that interplay is real. And you think about people, like, you think it just in microscopically, when you studied in school and you went a day or two without sleeping and pulled some all-nighters, right? Or partied and drank and pulled an all-nighter and didn't get some sleep and then tried to function the next day, you're irritable, you're angry faster, right?
Yeah, ready to snap at your girlfriend.
You're ready to snap, your mood's not great, you can't concentrate.
More likely to use drugs again.
More likely to make
better.
Bad decisions, right? So it's like, that's what happens when you're not sleeping.
Yeah.
And what happens when you do that chronically? You're decreasing your ability to be your best self.
Mm-hmm.
So I think that, the wanting to look better thing is interesting because when people they look in the mirror and they see their jaw is weak and they want to look better, it doesn't take away from the fact that their jaw is weak and that's causing health problems. So a lot of times an aesthetic concern to me, whether a patient knows it or not, comes with a functional problem.
Yeah. And does that give you, it consoles you when you feel like you're being presented with a sort of body dysmorphic Looksmaxxing patient who is really here for aesthetics, but
Right.
it's just a 17-year-old or an 18-year-old, or maybe let's say a 25-year-old who they're really doing this for aesthetics, but you know that there's going to be a functional benefit that comes from this. And maybe
Right.
the sleep apnea just hasn't caught up to them because they're still in that glow of youth, so to speak, where they're invincible to the sleep apnea and to pretty much abusing their body in any number of ways and not feeling the outcome of that.
Yeah.
Whereas these things do tend to catch up with you somewhere around age 30 has been my experience.
Yeah, definitely.
Shit all of a
It
sudden
definitely
hits the
catches
fan.
up. Yeah. And I think that, that's why biohacking tool is the best way to frame it, I think, because even if you don't have sleep apnea, breathing better is going to make you perform better, and exercising, in sports, sleeping better. So it's like we should look at it more as an optimization thing. Yeah, I think in medicine, we look at treating end stage diseases to a fault. It's like people don't really stop drinking alcohol until they're diagnosed with cirrhosis, and people don't start eating clean until they're diagnosed with diabetes, and blood pressure is not really treated until there's a
heart attack.
There's this, or there's a certain number threshold that somebody determined requires treatment. And that's how medicine is really looked at this day and age. And it's not really looked at making people the biohacking. The biohacking is really optimizing health
And preventative.
and making people feel better. And I think that medicine should really strive to make people healthier rather than just focus on treating disease or what we determine to be a threshold for disease state.
Yeah. Yeah, now all of a sudden I'm thinking in terms of Dr. Peter Attia's Medicine 3.0. Mm-hmm. Is it Medicine 2.0 or 3.0? Anyway, he has this vision of Medicine 3.0, which is more focused on preventative treatments. And so I'm thinking that in addition to an Andrew Huberman interview, maybe a Dr. Peter Attia interview would be good for you. And maybe you can, because he doesn't have the best jaws in the world either.
Right.
And he's another one that's always talking about how he's got every aspect of his life perfected.
Except the sleep.
Yeah, and he's working on all these crazy sleep technologies.
Right.
Like, I don't know what he's up to now, but he's pumping like tons of money into the next greatest gimmick, not gimmick, but widget.
The workaround.
A widget to help him sleep better.
When it's always the jaws, right? Or in his case, or in most cases, it's the jaws. And I think that falls into, what we know is this surgery to be. It was a difficult operation, unpredictable, unstable, and not something that anyone recommends. So people just dismiss it as an option, really. But that's based on traditional realities, not what we can do now and have a predictable, stable outcome. And for most patients, a difficult week, and then a lifetime of betterness.
Right.
But I think that as this continues to improve and there's more providers that are doing it and it's accessible and becomes more mainstream, we'll have a completely different popular belief system around all of it.
Yeah, I totally agree. Who's another one in that boat of optimizing up the wazoo, but can't get his sleep right, is Dr. Paul Saladino, the carnivore MD.
Yeah.
Who's also got noticeably deficient jaws.
Yes.
And I'm starting to think that anytime you have a hardcore carnivore guy, and this isn't like an anti-carnivore thing, because I think both you and I are open to like a protein fat first diet.
Yes.
And I'm a big carnivore guy, and that's probably because of my sleep disordered breathing. But I think that anytime you see carnivore diet, Peter Attia as well with his Maui Nui Hawaiian venison product, like he's huge on meat. Whenever you see carnivore diet, there's sleep disordered breathing. Yeah. Because it's such a cope.
True. Yeah. I mean, you're trying to do everything you can to feel better.
Yes.
We all now eliminate alcohol. I eliminate alcohol.
Me too.
Because that's going to be detrimental to my sleep and breathing and make me sicker. I work out, exercise every day. I also eat very high protein and fat diets, low carb, and really trying to do everything I can to optimize my well-being, and that means staying leaner, having better sleep, having better breathing. So I think you're right. I think, if I had amazingly strong jaws and an amazing airway, maybe I'd be eating the American diet
and get away with it and still feel pretty good.
Right, exactly.
Because if you're burning hotter, if you have more oxygen and you got a bigger flame, you might be able to rip through more bullshit in your diet.
Exactly. And then you hear about people like, you hear legends of some athletes that are like, that guy was out partying all night, like Dennis Rodman, right? Partying all night, drinking alcohol, didn't sleep. Then he comes out and goes on a treadmill for 4 hours sprinting before the game and can outwork everybody in the game. It's like he can get away with a lot because he's optimized.
That's incredible. I didn't know that story, but that really is to the point.
Right. Yeah, he's notorious for that. And, you can go back and watch the film in all these games. He's outworking every athlete on the court.
Yeah, and has a noticeably blocky head.
Yeah.
He's got a good head.
Large nasal passages, very large nostrils, and square jaw. And how much of that was airway?
Mm-hmm. Yeah, it's only a matter of time, I think, until the mainstream biohacking podcasting community picks up on procedures like the one you offer. Rogan, Huberman, Dr. Peter Attia, Dr. Paul Saladino, Gary Brecka. And I think once they get it, when it comes to jaw structure, I think it's going to be a huge, it's going to be the next big thing
for them. Yeah, I think so. And I think it's right up in their arena in this whole biohacking community. To their credit, I think that they just haven't been exposed to this.
Yeah.
But I think it's a matter of time.
We got to get you those interviews.
Yeah. I think it's a good time. I think we're at a tipping point where there's, even in the medical community, the dental community has embraced airway. A lot of the continuing education is on this. I get asked more than ever to give talks. I have to say no to many of them because dentists want to learn about this. It's at the forefront. And the same with medicine. Medicine's starting to catch on with it. And then, as you know, outside of medicine, the population is hungry for this information.
Correct. And we were talking earlier, I think a lot of the reason it hasn't gone totally like batshit crazy in the mainstream is because it lacks the right buzzwords. Yeah. Like the biggest buzzword in this space is airway, I guess, or mewing. Right. Which mewing is sort of associated with inceldom. Right. With like Gen Z, insecure people that are unhappy with the way they look and they see it as a kind of misguided vanity process, right? Which is wrong, but that's the perception at least. Yeah. And then when you talk airway, what did you say earlier? When you hashtag airway, you get like American Airlines, American
Airlines, United. Think about the friendly skies. People are not really, the general population is not thinking about jaws when we say airway. So you're right. We don't really have a good buzzword. We talked about is breathe a better one,
Yeah, but breathe can mean anything.
It can mean anything.
Does it mean meditation? Because breathe is more like mindfulness.
Correct. So it's true. You're right. We got to figure out a better word for it.
We've been brainstorming that. Yeah. I came up with paleo face.
And I like that. To me, that makes a lot of sense.
But the paleo movement is kind of dead. It's been a little bit surpassed by straight up carnivore.
You're right.
But maybe it has to be resurrected for this one last use case. Yep. But no, for real though, if people see this interview and they think that this should reach the likes of a Huberman or a Dr. Peter Attia,
reach out to them, push it,
share it, and because
share it to them.
Usually those guys have forms where they ask you to who should I interview next? Like, give me a name that I don't know that's worth talking to. Yeah. They should share your name.
Right. I think if the public can reach out, this is information that they're going to love to have. Yeah. On there. I think they just need to be exposed to it. So it's just about getting the right channels.
Derek from More Plates, More Dates.
Yeah, Derek would be great.
Another one with visually deficient jaw structure who's constantly talking about sleep, but doesn't quite understand the connection between his retrognathia and his poor sleep.
Right.
Because he knows all those guys, so that could be another gateway.
Yeah.
But
yeah, absolutely.
It's only a matter of time, right?
I think so. I think so. I think the time is ripe.
Time is ripe.
Yeah.
Time is ripe. I mean, I think we've been talking probably, I don't know how long, definitely over 2 hours. But before we wrap up, what do you see on the horizon in terms of your own practice and in terms of how can you make your process even better?
Yeah.
What do you see coming down the pike?
Yeah, I mean, I think embracing the holistic approach, because I think it's more than just surgery. I think it's a real tool to make people better, but it's not a one-stop thing. It's not surgery alone does everything. You know, I think we have a nutritionist because I think health is important. We have a psychiatrist because I think mindfulness and mental health is an important aspect to it. But I think that, you know, trying to continue to incorporate as much well-being with this will make outcomes better. You know, increasing the access. I teach a fellowship every year and train someone by my side how to do this operation. Been doing it for multiple years, and growing the amount of surgeons here that can offer it, I think is going to be, I mean, it's obviously in the mission for us, and continuing to think about every case and learning from all of them and how to make it better, how to continue to get better outcomes, and a better, I would say, experience for people, and continue to be open to new techniques, tools, technology. And, you know, the way I do it today is different than a month ago. And I hope that continues to be, just continue to get better.
Well, that's very exciting. And I appreciate you having me this week.
Yeah,
and
it was a pleasure. It was a lot of fun.
It has been a lot of fun. I did not expect it to be fun. I thought it was going to be a lot of hard work.
Right.
But it's been fun. And I've learned a lot. Yeah. And sure, I'm going to come out of this with some good content. But I think mostly what I've gotten is a lot of good inner content. Yes. Which is going to help me be better at what I do. Yeah. Sort of guiding patients through this space. So Dr. David Alfi, thank you very much. And I appreciate your friendship and your instruction.
Yeah, same here. It's mutual. Appreciate you and what you're doing. I'm glad you're out here.
Thank you so much, Doctor.
Thank you.